Manager, Cepheid India. And virtually, we have along with us Dr. Sabahat Azim, Founder and Chairman, Global Healthcare Systems Private Limited. I request each one of you to kindly put your mobile phones on silent mode or vibrating mode so that we have the smooth session on. And I now request our moderator, Mr. Karan Singh, to take over, please. Thank you.
Morning to everyone. Thank you for inviting me. It's an absolute privilege to be here. We have a wonderful panel, and we've had a few dropouts, unfortunately, but I see some stalwarts in the front row that we will co-opt. So, but it's a wonderful panel, and looking forward to the session. I think the proceedings start with Dr. Lal, who's the convener. I think, Dr. Lal, if you can have your opening remarks, and then we'll get into the panel discussion.
Thank you, Karan, and morning, ladies and gentlemen. And rather early in the day to start, but it's nice to see so many people here collected for this so-called important public health or primary health session. So I welcome all of you again to the second day of Heal conference, Ficci Heal, and to this session on leveraging technology for transforming primary health care. So as the first pillar of Aayushman Bharat, the government has operationalized more than 1.6 lakh health and wellness centers across the country. Health wellness centers are a significant lever to attain universal health care when they are equipped to provide the full spectrum of services envisioned in their scope, for which we need to overcome system as well as grassroots level challenges related to number one, shortage of human resources, number two, timely procurement of essential supplies, number three, utilization of funds, number four, availability of essential diagnostics, and finally, the last mile internet connectivity. In a country where more than 70% of all outpatient health services are provided by the private health sector, it is imperative that the private sector contributes its experience and expertise in successful running of these HWCs. This is completely in line with the announcement of HWCs in the Union Budget of 2018, where the government also sought the participation from the private sector to partner in these centers. The private sector has also been at the forefront in the adoption of the latest technology and innovations to deliver quality healthcare. Therefore, it is crucial for the government and the private health sector to work together to make these HWCs into more effective, what we call smart HWCs, by leveraging better management practices, technology, innovations, and digital health solutions. Many of you are aware that Ficci is spearheading a health industry-wide movement in primary healthcare with Nat Health and OMAG through the project Smart HWCs. For the first time in the history of Indian healthcare industry, these three very prominent associations have joined forces through their 300 plus health sector member organizations to work with the state governments to create demonstration models of Smart HWCs. Smart HWCs are an advanced form of HWCs that will be equipped to provide the entire expanded range of services envisioned in the operational guidelines for comprehensive primary health care or CPHC. These smart HWCs will leverage technology innovations and digital health solutions to overcome systemic primary healthcare gaps and ensure access to comprehensive, preventive primary healthcare gaps and ensure preventive, promotive, and curative and rehabilitative healthcare services for the community. Smart HWCs will ensure access to consultations with doctors via telemedicine, provide essential drugs and essential diagnostic services using a hub-and-spoke model. These advanced HWCs are envisioned to deliver notably heightened quality and standard of care after the upgradation. A similar project is already being implemented with the government of Uttarakhand in Almora district by my personal philanthropic trust known as the ALVL Trust, or Arvind Lal Vandana Lal Trust. ALVL Trust and the Ficci Nat Health OMAC collaboration will be taking up Project Smart HWCs with the government of UP and the government of Chhattisgarh, which are both priority states for improving healthcare. We are in the final stages of signing the MOU with both the NHM UP and NHM Chhattisgarh and hoping to kickstart the project by the end of this quarter. We tried very hard that the MOUs could be signed today, but well, you know, when you work with government departments, well, it's not that fast. Therefore, for this session, we have brought together stakeholders from the government, from the industry, for collaborative dialogue and deliberation on key tenets of creating model smart HWCs across the country. So I'm delighted to introduce the distinguished speakers today. First of all, I have the pleasure of introducing on my right side, Dr. Akshay Jain, a medical doctor and Joint Director, National Health Authority, Government of India. Dr. Sabahat Azim, who will be joined on the virtual mode, co-founder and CEO International, Up Health Incorporated, and founder chairman, Global Healthcare, and former a lot of hardware and technology for overcoming the TB problem in India. And well, he'll talk about it himself, I'm sure. And last but not the least, the moderator of the session, Mr. Karan Singh, chairman of Bain & Company India, who has been at the forefront of advising and guiding the healthcare industry through its course of transformation. And every time we have a problem, we lean very heavily on Mr. Karan Singh. So Karan Singh ji, thank you very much. Now I have the pleasure of giving the floor back to Mr. Karan Singh for the proceedings.
Thank you thank you, Dr. Lal. You're always very kind and generous. But let me start by echoing a point that Dr. Lal made, which is the primary care needs to be the cornerstone of any sustainable health system. And I think it's if you look at the title of the session today, I think we absolutely need to think transformatively about how primary care can be fundamentally changed, and in terms of getting to a full potential. I think we are all pretty aware of the challenges where we massively underconsume primary care. Our incentives are not skewed or are not focused on health-seeking behavior. It is an unorganized sector where there is massive shortages of personnel. I think we're all probably very aware of that. And there's a lot of opportunity for us to really use this to create a much more sustainable system. I think, as Dr. Lal said, great set of panelists. It's delightful to have everyone here in spite of a couple of dropouts. We will start with Dr. Akshay Jain. It's delightful that you've joined us, Dr. Jain. But we've got policymakers at the highest levels. We've got private sector players, innovators. We've got tech partners, quite super impressed with what Path is doing. And Swati will talk a little bit about their partnerships and their involvement in multiple states in India and multiple programs. And then again, Dr. Lal can talk a little bit about the NGO sector as well. So I think we hopefully will get a pretty holistic view of how do we think about using technology to transform primary care. So with that, let me start first with asking Dr. Jain, thank you again for joining. But I think everyone is very keen to know about Aayushman Bharat. Maybe we'll start a little bit more broad and then take it to primary care. But if you can help us think with how is Aayushman Bharat 2.0 being envisioned, and from the perspective of primary care, and especially everyone's talking about the missing middle, and then how do we think about outpatient coverage, primary care coverage? Maybe start there, and then we'll talk a little bit about the digital health mission.
Thank you so much, sir. A very good morning to everyone, the distinguished panel on the dais, and distinguished audience. Aayushman Bharat, obviously has been said that we had 4 pillars in Aayushman Bharat. One was focusing on digital, another was focusing on the health assurance scheme, another was focusing on the infrastructure that we have in our country, and another was related to HWC. Now, Honorable President has inaugurated Aayushman Bhav campaign in last September. In that campaign, we are doing door-to-door surveys, conducting Aayushman Melas, making all the beneficiaries of insurance scheme or Aayushman Bharat Pradhan Mantri Jan Arogya Yojana getting their insurance cards or Aayushman cards. We are approaching every village and everywhere on every door, so that everybody gets an Abha ID also. And by this mass campaign, we are hoping that the population coverage of the insurance scheme as well as for the digital mission would increase. So, and also we are thinking that in each HWC we are going to post the a medical doctor, so that the primary health care is taken into account at the level of CSC. Sir also talked about the missing middle. For missing middle, we are thinking that we are going to converge more insurance schemes with the Pradhan Mantri Jan Arogya Yojana. By those conversions, we are trying to cover more and more people. Jan Arogya Yojana currently covers around 40% of our population, but we think that more people are going to be covered if we include and merge other insurance schemes like CAPF scheme, CGHS scheme, ESIC, etc. into the insurance scheme, and then we converge all those schemes and make them use the single platform, so that duplication of effort or development of platform is also avoided. Then we come to the digital mission. Digital mission is I'll say an umbrella which is covering the insurance scheme as well into it. So insurance scheme would only be a single integrator in the digital mission. Digital mission hopes to cover all the population of India, and it's open to everybody. We already have around 47 crore Abhas in the country. But digital mission is dependent upon the integrations, because India is a diverse and large country, and therefore we can't put a single solution for everybody, and therefore we need to integrate with different solutions. It is estimated that more than 3,000 different healthcare solutions are being run in the country, but that is, I think it's a rough and low estimate. There are many solutions, and we are integrating them with us, and we are hoping that these solutions will take the digital mission forward. For example, in primary care, most of the primary care is being delivered at the PSC and CSC level, and in this year itself we have integrated non-communicable disease program in the country. Non-communicable disease program is having largest beneficiary base in India, and unfortunately we have large people who are suffering with these non-communicable diseases. Since their integration in this year, we have seen that they have created around more than 4.5 crore Abhas on their system itself. In the last month itself, they have created 60 lakhs Abhas, so they are creating 2 lakh Abhas every day. And they are linking records, whatever digital records are getting created in that NCD program. Those digital records are getting linked to those Abhas also. They have linked around 3.5 crore digital records with those Abhas, and last month itself I think they have linked around 30 lakh digital records. So these digital records are now accessible to the people who are present in the villages, and those digital records can then be used by them when they seek secondary or tertiary care. So with the kind of internet connectivity or mobile phone penetration that we have around, if I'm correct, 600 million smartphone users in the country. So if we combine all this, then I think we are trying to reach a point where people are going to seek healthcare delivery in digital format, even in the primary healthcare. And when they do so, they are going to come to the urban areas, and then when they seek secondary or tertiary care, they their records would be then accessible to them on their mobile phones or maybe. So this is the overall way how primary healthcare is being taken into account as a central focal point by the government of India in Aayushman Bharat campaign and different pillars of Aayushman mission, all 4 pillars.
No, it's great to hear about how you're thinking more very holistically, and especially about the digital records and the digital that allows everyone to have access to their issue. What about the challenge? Always has been skilling. What about the use of the digital health mission on skilling? How are you thinking about that? And anything on incentives of, how do you encourage? There is clearly the HWCs, but anything else on incentives? You talked about your merging schemes, but any comments on it?
For incentives, digital mission, the technology is already ready. So by the scaling or by the technology, I'll say that on 30, I remember the date because 30th January 2023 was a date when we linked 4 crore records in a single day so the technology is ready. Now the battle is for the adoption of it. We need to change behavior of people so that they seek, also the healthcare professionals also provide healthcare delivery in a digital format. Not only people can avail or book services online, but also seek services online and also seek digital records from. So it's a change of adoption. So for adoption, we are thinking that a small way could be providing incentive to people. And we have one digital health incentive scheme which is running since January 2023. In that we are providing around 20 rupees for every digital record that is created by any software solution or any healthcare facility, includes laboratories as well as the hospital facilities. We are also incentivizing the digital solution companies who have developed that kind of solution. So 25% of the incentive which the facilities get, 25% of over and above that incentive also goes to the digital solution company. So digital incentive is one way, but another way is providing use case or easing their journey when they seek healthcare. So we want to make it like they think that this is easier way of seeking healthcare. So another way what we did is, in public healthcare system we have initiated this scan and share scheme, where people are just scanning the QR code, which is interoperable and seamless, which can be scanned through any of the mobile phone application, not only the government mobile phone application, but any mobile phone application which is integrated with us, like Paytm, Briefcase, EkaCare, Aabha, Setu, Bajaj Finserv, several mobile phone applications. You can scan the QR code and get yourself registered. So that scan and share thing eases the journey of people when they seek healthcare in public healthcare facility. So that is one way how we want to change the behavior and ask people to provide healthcare digitally. We are also initiating microsites. Microsite is especially focusing on the private healthcare providers in the districts. Currently, we initiated this idea in April 2023, and currently we have around 24 microsites in the country. We are hoping to reach 100 by next March, and these microsites, we are targeting a specific geographic area where all the healthcare providers, especially the private ones, not the large corporate hospitals, because they already have digital technologies and providing digital healthcare, but the smaller ones also. So people are approaching them, asking them to get onboarded on ABDM, creating their HPR, HFR, and start using the ABDM enabled software solutions when they provide healthcare to people. So we have around 24 of them in country, Uh, uh, Maybe Madam is going to tell more about it, because PATH is also associated with us in development of microsites. And these microsites, we think that is going to, in a specific geographic area, if a person goes to a doctor, he gets a medical prescription which is available on his mobile phone. The same prescription he can share with the diagnostic laboratory. The same prescription he can also share with the pharmacy also. So if people get to see that yes, this eases their journey when they seek healthcare, maybe then this is another way of tackling the adoption part of our digital.
No, very impressive. Great to hear. Any follow-up from Doc or Swati or Dheeraj? Any questions? Otherwise, we'll get the other panelists. Anything on skilling, Dr. Jain?
Skilling, we are thinking of initiating a digital course in several. We have approached IITs, IIMs for developing a course on digital health. We have also approached different foundations, private foundations, that a course can be established in the universities, in the medical councils. The set course, maybe a smaller course of 6 months, 4 months, can then be given to the medical doctors when they do their MBBS, and then they can get initiated to the healthcare, which can be delivered digitally also. So that kind of development of a course are there. We have approached IITs and IIMs. We are thinking of entering into some MOUs so that they develop the course and we only provide some inputs about health.
So you're thinking extremely comprehensive. It's great to hear this. Wonderful. Just watching the clock a little bit, going to Dr. Azim. I think you're on VC with us. Can you hear
Yeah,
me?
hi, Karan.
Yeah. Thank you again for joining. I think just picking experience on public health and the models that you are experimenting with, the low-cost models, the PPP models, the primary care models. If you can just pick up on the point about how do you create health-seeking behavior in the communities, and then second is, with all the experiments that you're involved with, how do you think about the scalability and the of those experiments? That would be terrific.
Thank you, Karan. So, the 2 points that you raised. First, just to give a brief background, we are in India, I think we might be the largest private sector providers of digital primary healthcare, with over 600 digital dispensaries providing from consultation, digital consultation, investigations, examination, medication, everything all in one. We are also in Philippines. We have been in Africa for some time now, but there have been some significant challenges. One government where we were providing the entire primary healthcare has seen a military coup. So we've lost a lot of money and time in Africa. I'm of course for the international part based out of Dubai right now, but we do millions of complete comprehensive digital health consultations every year. And we are from eastern part of Asia, Far East, which we call, and hopefully this year we'll announce something in the Americas. So we're working on it. We hope. Africa has been a tough journey. So we are not at an experimental stage. We are pretty well scaled up, and we do hundreds of thousands every month. The 3 points that I would like to make here. One is that you see, when the paradigm shifts, there will be a lot of half-baked solutions. There's nothing wrong in that. That is the way when we transform. So you would have things like hub and spoke model, people thinking that digital health is about just putting a video between a doctor and a patient. Might be considered negatively, but that is not true. You should consider it as part of a movement across the globe. So healthcare has 3 verticals: pharmaceuticals, medical devices, and delivery. The first 2 are very much technology oriented, and you don't even talk about them because it's understood. But on the delivery side, we still live in the Stone Ages, and we are now beginning to transform, and you will have a lot of different kinds of solutions, and all of them, and the government should not be rushing to try and regulate the sector, because it is out of this chaos that the technologies for the future will develop. But one point I would make is that there is no need for a change of health-seeking behavior. In fact, the consumer is far more advanced than us. If you look at the hype created by the Huawei Watch Pro 4, which in China is already doing non-invasive blood glucose monitoring, you see this transformation is already happening on a regular process. And customer and the consumer is far more advanced than the deliverers, and they seek. And even in rural India, I can tell you we have been doing in Madhya Pradesh and Orissa. In Madhya Pradesh, we run over 500 places where NCD is integrated. We do hundreds of thousands of consultations there, providing specialists. Consumer is extremely very happy. You don't, in fact, the whole idea of trying to dumb down the rural population is totally incorrect. They are smarter. They actually survive in difficult circumstances with less money. They are the earliest adopters of technology. The young is also a very early adopter. So this is a total misconception. And I would say this problem is with the educated people who talk about this. If your product is good, if your service is good, the consumer understands it and accepts it. The ability is that when we ourselves don't know what we are doing and we do half-baked small things which really do not deliver any benefit to the consumer, he will not like it. You may think it is good, but he may not. So at the end of the consumer. So health-seeking behavior is not an issue. I think this is digital health. We need to move from our mind that it is about e-prescription or digital health record, or it's a completely different way of thinking about healthcare. We move out from stone ages to today's age, how you would deliver any other service. You do data acquisition, you do analytics, you do all the interactions, you have real-time data so that they're not people filling up data elsewhere. The whole idea of people going home to home and trying to do surveys, I mean, just need to move out of that. I won't stress too much, but I just think it is not the consumer which is the problem here. It is us. We need to just be with what is today already available. And I can tell you, you do it or you don't do it. It's happening. It's inevitable. It's going to transform, and it will you will see a very different format of healthcare delivery across the world. And it is not going to be led by the Western world, because legacy systems are a problem in change, but it is happening nevertheless. I will leave it to you because I think there are more questions and answers that I can give today.
Just a follow-up, you've talked a lot about being in the stone ages on delivery. What is the model that you're envisioning that will transform primary care? Can you define that a little bit?
See, as of today, what we do, and I'm just saying that even we are not in the stone ages, we are probably in the bronze age today. In our digital dispensaries, it is not just the consultation that happens digitally, the complete examination, from the doctor being able to examine the patient remotely by using multiple IoT devices. He is able to do the examination. All investigations are done at that village itself, including your liver function test, your kidney function test, within 15 minutes. So the patient doesn't have to come the second time. All medications are also delivered in a more advanced model automatically the moment the prescription is done. Behind it, there is a semantic algorithm-based AI that helps in. So there's a clinical decision support system that has now crunched millions of patients' real-time data. It helps the doctor in making the diagnosis. It checks for drug safety, from drug interactions to everything. So it delivers within, and we have delivered profitably primary healthcare, including consultation, examination, investigation, and medication at less than 250 rupees per episode. But I'm saying even this is actually a halfway house, because there is a possibility today with the current commercialization of technologies that, you see, primary care is the base on which your secondary, tertiary, and acute care rest. That's the base of data where you know about the patient from beginning, so that you are not looking for data when the incident actually happens. You can predict it in the future. The second point, the part that we are working on right now is what we have codenamed Galactus for us. It's basically a zero knowledge proof kind of an algorithm that avoids the whole question of HIPAA. Essentially, you don't need to know that your name, I do not need to know that your name is Karan Singh and you live in a particular place to be able to help in your diagnosis. So it's something which keeps your data privacy. It doesn't need a HIPAA layer to protect your data, but essentially provides the intelligence that is required at every interaction wherever you go, at whatever delivery point that you go, and keeps that record and keeps that track. And you store your own data on your own devices. but it's like a token that allows your identity to be managed across insurance and everything, but giving the AI for CDSS. We are still, I think, from an operationalization perspective, we're maybe another 12 months away from it. But by the time, I think we should be in Latin America, in some parts of America, Philippines and India. So we'll be able to combine, and hopefully if we can sort out Africa, it will be a rich data which will be coming out to predict what is happening on the ground. So it's going to be pretty different. It will be seamless, and it is not something which will be in your face.
Got it. No, I think same point even Dr. Jayanman made about digital records as used as a key enabler to transform and think about predictive healthcare and sharing of the data. Dr. Swati, I was quite blown away with what, and maybe this is my ignorance with what PATH is doing. So maybe just for the audience, just describe everything you're involved with on the primary care and then touch a little bit upon the impact labs and all the innovation you're seeing and some of the challenges actually on the regulatory side that you were mentioning earlier in the morning.
Thank you. Thank you for your question. So in terms of PATH's work on primary healthcare, so we've been working across around 5 states, and we are supporting more than 2,000 facilities for strengthening of the primary healthcare services. We work both in urban and rural settings because we believe that the set of interventions that you need for urban areas will differ from those in rural areas, because urban is different altogether, and there are determinants of health and governance which play a greater role in urban settings than in the rural settings. So our interventions are largely in 5 states. These include Maharashtra, Madhya Pradesh, Jharkhand, Odisha, and Manipur. In the primary healthcare work, the basic, intervention, or I would not say the intervention, the basic approach that PATH adopts is that primary healthcare platforms are just a means of service delivery. So the idea is to strengthen the existing health and wellness centers, work closely with the government stakeholders to ensure that we have a functional service delivery platform in the primary healthcare settings, and then trying to layer on that platform to ensure that there is access to affordable and quality healthcare closer to the homes of the people. So what we try and do is the focus here is on integration. We're saying that for health systems resilience, it's now very important that we move from fragmentation to integration. Some of the core tenets of our approach include integration of various national health programs. Rather than working in a verticalized manner, how can we make health and wellness center as the point of care and try and integrate and layer various interventions there? The second tenet that we work on is, I totally will agree with Sabahat's point on, it's no longer that we want to give the communities and, we just think that we know everything and the communities are not aware. So there are gaps in literacy in some pockets, but now communities are quite aware about their needs. So, this entire way of designing healthcare that we know what they need has to change. So communities have to be at the center of all the programming that we do. So at PATH, we adopt a human-centered design approach. We globally have a program that's called Living Labs, wherein the essence is that you adopt a human-centered design approach. You try and understand what are the barriers and facilitators to seeking healthcare. What are the moments of transition when your communities or your clients or your patients, they switch between the public and private health systems, and how do you want to capitalize on those moments of transition to make sure that the interventions are designed the way they should be. Using this approach to also redesign the entire referral experience, because we understand that a lot of patients come to primary healthcare settings as their first interface, but then you lose them. Either there is loss to follow up, either they switch between the public and private sectors, either they go to the informal providers, but there's some loss that happens. So a lot of this is also because apparently the out-of-pocket expenses or maybe other factors. So how do we improve and redesign the entire referral experience? Then our work is also around deploying a lot of innovations to leapfrog some of the current challenges in the primary healthcare delivery. We believe that innovations are anyways a core and center to PATH's work, and driving fit for purpose innovation is something that we do, not only in terms of driving product innovations, but also looking at process innovations on how you can restructure, re-engineering the processes to make healthcare a better experience for the clients. So all in all, and since you've been asking about the Impact Labs, so Impact Labs was an initiative that was set up by Path around 5 years ago, jointly with support from Tata Trust and Bill and Melinda Gates Foundation. However, we are now continuing it, and for us, Impact Lab is like an entity or a platform, which is a robust pipeline of innovations in various areas. Like we have a robust pipeline of innovations on primary healthcare. We're now building a pipeline of innovations on climate and health. We also have a pipeline of innovations on maternal and child health. So through Impact Labs, what we do is we scout innovations which are already a proven proof of concept. We do not incubate. We look at the innovations which are at a technology readiness level of 8 and 9, and then we see and try and pilot them, deploy them in the public or the private health settings to look at what are the refinements that are needed in the product design, sharing that feedback with innovators, working closely with them, providing them access to the health systems, and also at the same time helping them with their market validations, their regulatory compliances, or maybe things like their go-to-market strategy, wherein they can actually be mainstreamed and they can be scaled up.
So I'm just curious, what are the breakthrough innovations we could expect? Just whether it's product or process, just maybe.
So some of these,
and the challenge there you got on the regulatory side, you were mentioning a few.
So there are many innovations that are currently being piloted and tested in our own programs. I think I would rather want to categorize them because the needs are different. It does not work like one size fits all. Some states might have different needs than others. So for example, last year, a couple of years ago, we did the Primary Healthcare PHC Tech Challenge, which was in partnership with a lot of other partners, including the Center of Biodesign at Stanford and the Office of the Principal Scientific Advisor. So in this, we tried to look at 3 major categories of innovations: medtech, cold chain equipment, and then equipment for screening of non-communicable diseases. So we are currently deploying at least 5 such innovations in building a model of smart PHCs. Sir also in his opening remarks alluded to smart health and wellness centers. So we are working in the Satara district of Maharashtra, which happens to be the Chief Minister's district. So, he has this vision of building up smart PHCs. So to begin with, we're working on 17 smart PHCs, wherein we are deploying a suite of innovations to build a continuum of care around non-communicable diseases to begin with. So we've brought in Niramai, which is the use of thermal analytics and imaging for early detection of breast cancer. Then we're deploying innovations for cervical cancer. Then we have a point of care spirometer to look at early detection of COPDs, and then AI Steth, which helps to look at heart irregularities in heart rhythm and murmurs. So we are trying to deploy these, and we're trying to also integrate them with the eSanjeevani platform to make sure that at the same time you can also look at the findings, and then they can be the patients can seek care and consultation at the high level by linking the PHCs with the next level, which is the RH. So in terms of some of the challenges that we see, I think one of the biggest challenges is the regulatory landscape. The innovators don't know where to go. They really do not know how to crack the process of health technology assessment, and whether they to go to ICMR, whether they are to go to NHSRC. They keep moving between one department to another. So I think there's no clear guidance or no clear protocol on whom they should access. Then the second thing is, I think the way procurement happens in the government systems, and I'm sorry for quoting this here, but I think sir will agree with me that everything some of these are really proprietary products, right? You do not have 3 quotations and 3 innovations to come in to select one. So, I mean, while there are many innovations which may be useful and may have a larger public health impact, but how do you actually bring them and mainstream? Organizations like us can only support pilots, but the scale cannot come from partners. It has to come from the government. So how, some things like these can be done. There are some, ways that the government is now trying to look at, but I think for the innovations to mainstream into the public health system, there has to be some way that we crack these procurement systems, and the innovations cannot be listed on the GEM portal.
No, thank you for being so candid. I think these are huge issues that we need to overcome. Very impressive to hear about the disruptive technologies you mentioned. I just will take 2 more minutes. I think it's wonderful to hear what you're doing on mental health and NCDs. And what you were describing a little bit earlier is, again, this whole concept of integration into the national health program. Maybe just talk a little bit more about how you guys are really at the forefront of this much needed effort.
Thanks. So in terms of mental health, so last year we did a landscaping to understand the policy landscape for mental health, especially with a special focus on adolescent mental health. We wanted to look at what are the provisions under the existing RKSK program or under the school health and wellness program, and we looked at and we found that there was not much about mental health. And as you would agree that youth and adolescent mental health is something which is coming up as an increasing issue. Exam stress, internet bullying, substance abuse. There are many challenges to the mental health, especially of this population. So how do you address those challenges? So based on our learnings, we did some pilots in Maharashtra, wherein we tried to integrate some specific interventions in the RKSK and school health and wellness programs. We've developed a series of literacy materials that can be given to youth, simple stories, and we also did develop a WhatsApp-based chatbot. So this is like more of an info bot, using some keywords you can just ask and understand what are the challenges that you're facing, and then it takes you to the government websites, or it links you to platforms, or it links you to care. In terms of our larger, so learning from that landscape, and we are also doing a policy landscape for mental health for 22 countries across the world. It's funded by Wellcome Trust, and it's a very, very insightful landscape that we are looking at, and that helps us also to understand what are things that are happening in other countries that we could adopt here. So basis all these learnings, and especially given our work experience in the primary healthcare settings, we're now working with the Ministry of Health and Family Welfare to talk about there's a need to standardize and have a standardized framework for integration of mental health across all national health programs. Every program comes up with their own interventions. If you go to maternal and child health, they're talking about postpartum depression. If you go to elderly care, they'll talk about depression in the elderly. Likewise, people living with HIV, those basically have their own mental health issues, but there is no standardized framework. So now we are looking at how a framework can be established to integrate mental health across all national health programs, so that there is a clear guidance. And when this means that there will be a framework, it would also mean there will have to be inputs for this framework to be delivered and operationalized, which means we would need some skilling of our health workforce to be able to, because mental health is it's like you have to be more sensitive, you have to be more understanding, you have to be able to screen in the primary healthcare settings, you have to be able to, we only have 2 questions in the CBAC form, and that does not help us screen those cases who have mental health conditions. And at the same time, there is a need to increase the availability of psychotropic drugs, maybe by introducing them in the Jan Aushadhi scheme, looking at professionalization of the workforce. I was amazed to know in a talk on the National Mental Health Day that Dr. Paul delivered, that in a year, our country produces only less than 1,000 psychiatrists. So, we need to work on availability of the workforce, especially when we are now realizing that this is a big issue.
No, thank you for being at the forefront of a much needed effort on NCDs and mental health in particular. I'll just shift to Dheeraj. Dheeraj, you've been very patient, but I think there's a huge theme around massive disruptive innovation. So describe a little bit about what Cepheid is doing, but Swati's point is an important one. How do you take it mainstream? How do you scale? What are the big challenges? What has worked? What has not worked?
So first of all, thank you, Karan, for asking this question, and thank you, Dr. Lal, to set up the tone for today's discussion. I was actually noting some points in different panelists, what they were speaking about, and what comes to my mind, apart from whatever I've written, right, is I think let's be very simple, and I like your statement, Swati, in terms of process innovation. What I believe today's health and wellness center infrastructure, it's heartening to know about the smart HWCs we are planning. But I believe we need to be innovative in terms of process delivery of execution, right? We don't have a dearth of technologies available today in India, for that matter. It always not depends on the product innovation always. How do we execute the deliveries? To that point, how can we make and enable these HWCs deliver to the last mile to the patient? My sense is there are few enablers which can really help us to address this issue. Number one, we need to work more collaborative between government, private, and the non-profit organization, much more than what we have been doing till now, right? And then those platforms should be made more easy for accessing each other, trying to understand each other's languages, and to your point in terms of regulatory, making things easier for us. Other enablers could be, one is how to choose the right technology. And you said very well, right? Right technologies cannot be made available on GEM procurement, right? So I also believe so. We need to be conscious enough to understand the impact of the technologies available today if we need to address the diseases, right? And coming from the TB background, I can definitely say that if we need to eliminate TB by 2025, we have to reach to the last mile patient and make that technology available to them, right? And when I say technology which should deliver quality, right, which should reduce errors and don't miss out on the infected patients. Second, the ease of use and low maintenance, right? We have a resource crunch at HWCs, we have a skill crunch at HWCs. How to make the ease of use of technologies available to HWC so that any unskilled operator, any unskilled last mile person who is handling those things can really execute that. A third point is the speed on which these technologies work, right? How do we screen more patients from diagnostic world I'm talking about, and the flexibility you talked about, the fungibility of the technology across the disease platforms, right? So these four things come to my mind. Second is the penetration to HWCs. And I again take example from the world which we are operating. We are having 1654 installation in the public space today in the TB program. But out of that, only 250 instruments are actually installed in the PHC and HWCs, right? So you can really see the strength of what, and as Dr. Azim said, the consumer is aware, right? They are ready to adopt, right? How to really make that happen, the penetration, how to make that happen.
What would you suggest?
So I think, again, the process in terms of the procurement and deliveries of these technologies made available to HWC, the infrastructure what we need at HWCs. For example, if I need a sort of a power over there, it's a very minimum requirement of having a power point there, having a internet connection, as you said, makes things easier, right? But still we are very, very far ahead. And I could really see that happening in the private world when Dr. Azim was talking about reaching out to the last mile. I think if you have to make the digital healthcare available to the last mile, the basic thing is having a net connection, right? So that's the third thing, which is very important. And I take the lead from Swati, what you spoke about, structured program to scale up and make this available technologies across national disease programs. For example, today, I again take example of my own self, 1654 instruments. Gene Expert platform is capable of doing screening of diseases beyond TB. We can screen HPV, virology, respiratory, AMRs. How can we make that fungible under common national program? How can we make those connectivities happen? So I think these are the thoughts, and there is definitely a strong merit in considering this expansion of national disease programs by some kind of advanced programmatic connections.
Dr. Jain, I'll come to you to respond.
Will I just add to one point, since you mentioned that you have more than 1600 deployments, but less than 200 in the primary healthcare and HWC settings. I think one point to note here is, having worked extensively on primary healthcare and health and wellness centers for 7 years, health and wellness centers are not on the TB care pathway in India. National TB Elimination Program is a vertical program. The peripheral health institutions, that is the first point of care for TB, is, health and wellness centers are not there. It was only in 2019, 2020, 2021, that we worked very closely with the ministry and the Central TB Division to actually develop an operational guideline for integration of TB services at health and wellness centers. But as you know, the time that it takes to develop a guideline and its translation on ground, there's a lead time in our country. Yeah. So I think that's one hook that you would want to actually look at to see how health and wellness centers can be put on the TB care pathway, and then you can, of course, bring
Thank you, Swati. Thanks for that clarification. Dr. Jain, we'll come to you because lots of points being raised about the government, and if you don't mind just responding or sharing your thoughts. I don't want to put you on the spot, but given you're on the dais, we cannot not come to you. But I'll give you some time to prepare. Make in India. You're doing a lot on Make in India.
Yeah.
Just explain a little bit about how is this going to be disruptive to more affordable solutions, Dheeraj?
See, we have been the partner for National TB Elimination Program for more than a decade now, right? And we have been partners with Global Fund across the globe for supporting the TB programs. And it was really perceived and understood, right, in terms of India getting 28% of the TB infected patient globally. So that makes a huge potential for reaching out to the patients, right? That's number one. Number two, strong impetus on making India for the world. There's a narrative, there's a story around it, right, for so many years now. Third, the geopolitical situation of India, not only in the Asian sub-region, right, but also globally, made a very compelling case for us to really invest in manufacturing in India. And I can really share with you, this is the third manufacturing facility for Cepheid outside Europe and America. So this is the first one in Asia. And the capacity buildup, what we have done in this facility is 12 million cartridges, which is not only sufficient enough to support the domestic demand, but also helping us to export to Asian and African countries for that matter. Almost 400 plus employees are there in the facility, and almost 40% of that workforce is women. So that's the scale. That's the scale we are building up.
Dheeraj, repeat that once again. Sounds too good to be true. Once again, what are you manufacturing in India?
So we are manufacturing the MTB RIF Ultra cartridges in India, which are used for TB diagnosis. And there is 12 million cartridges capacity is there today per annum. This facility was inaugurated in March this year, and we are scaling up the production. In next 12 months, we'll be able to produce 12 million cartridges. Today, we will be exporting to Asian countries like Bangladesh, Indonesia, Sri Lanka, Nepal, also to African countries, because again, those are the countries where we can approach. Every country has its own legal licensing issues and problems, so we are trying to address those issues. Other thing, Dr. Lal, what we are doing is, we are also making some kind of kitting processes for the US demand as well. So we are having some input materials, raw material from US, getting it and then sending it back to the US market as well.
Dheeraj, what about the cost curve? I mean, you get to 12 million. How much does the cost reduce?
So again,
what will you achieve?
That's an interesting question. So again, I think see, we have started with TB right now, right? And TB per se is a global phenomena as such, and we know. So I would like to share with you, recently in the last month itself, Cepheid globally in partnership with a Global Fund, USAID and Stop TB, they have announced the reduction of price for MTB RIF Ultra cartridges, and they have decided in concurrence with Danaher, which is the group organization, to supply this cartridge at cost to all the programs in the world which are supported by Global Fund. Coming to India, I think whenever you start a manufacturing unit, right, the cost depends on the scale of economy. And that is where I would like to really take that lead from what Swati spoke about. If we have a manufacturing facility to make molecular diagnostic manufacturing capabilities in India so huge, and we are the only multinational in molecular diagnostics which has 12 million cartridge capacity, and we have extended that price reduction to NTP for all their future procurement as well, and look forward to the government to really utilize this capacity for the benefit of reaching out to the last mile HWCs, right?
Wonderful to hear. Wonderful to hear that you're doing it at cost and that the scale is multi-geography. Dr. Jain, maybe just, and Dr. Lal, we are coming back to you on your topic of NCDs next. But Dr. Jain, if you want to respond to a lot of the points raised by the panelists. So we'll come to the group as well if there's one or two questions.
Many of the points have been raised for the government. I'll try to respond to some. Let me come to Mr. Sood's point that the infrastructure is one of the area which we need to improve. We need to improve it, and therefore Aayushman Bharat health infrastructure mission specifically caters to. In the health infrastructure mission, as I earlier mentioned, that Aayushman Bharat was taken as four-pillared approach and holistic approach from primary to secondary and tertiary. You see that HWCs catering to primary health care, Jan Arogya Yojana is taking care of secondary and tertiary care, digital mission is an umbrella which is changing or transforming how healthcare delivery is going to be transformed, and health infrastructure mission caters to the infrastructure that we need to install at the healthcare facility, in the specifically in the primary healthcare. Health infrastructure mission handles the internet connectivity, the power connectivity, as well as the manpower installation at the healthcare institution in the this healthcare infrastructure mission, which is named as Aayushman Bharat Health Infrastructure Mission PM Abhim, is I think I don't remember the actual amount that is being spent, but as I understand, the crores of rupees are being spent on this health infrastructure mission, which is going to take care of the installation of infrastructure in the primary health. Now, I know that various innovations, process innovations, and product innovations are coming up, and they can't be directly, or the procurement process of the government is not taking up properly, and not is getting a time is taken to procure them. But the changes have been there. I'll just quote one of the example that Swati Madam Path only initiated this microsite in Mumbai, and now when we saw that it was proven that changes can happen on a smaller scale, like Path did this microsite in Dharavi, where small healthcare professionals are asked to onboard themselves on ABDM, create their...
What is microsite?
Microsite, for elaboration, would be a small geographic area where healthcare delivery is being provided by different ecosystem players, like different stakeholders. A healthcare professional is there, a pharmacist is there, a lab is there, and the patient is approaching all of them. Goes to a hospital, goes to a clinic, goes to a pharmacist, lab, and he gets the healthcare delivery digitally everywhere. So he gets to feel that how healthcare delivery can change if I get digital delivery on all these from all these states.
And it's linked, right?
Yeah, it's linked from everywhere. So in Dharavi, healthcare professionals started using their mobile phones and their tablets with mobile internet connectivity. No extra effort that they need to do. Only a software as a system which can be compared to a Gmail, which we only download and start using. Those kind of software were being used by them, which on a subscription basis cost less than maybe 500 rupees a month. And then they start using it, provided digital solutions, registering the patients online, and giving them digital prescriptions on their mobile phones. When Path did this in Dharavi and around area, in I think 7 wards of Mumbai were covered, and then we thought that we are going to take it up, and then we took it up to our highest body meeting, and their honorable health minister approved it, and now we have taken it up that we are going to launch at least 100 microsite in the... So we have already done some work over it, and around 25 of them I have already. So government is trying to take up some innovations from different private players and trying to scale them up.
Very impressive, very impressive. Great to hear. Thank you for responding. Appreciate that. Dr. Lal, you're the last word on NCDs. Right, Om is laughing. No, but on a serious note, honestly, we've heard a lot about how NCDs, how people are working on NCDs. The big theme I'm taking away from today is about tremendous innovation, lots of efforts to think about scaling, but also about partnerships. So help us, you're doing a lot with smart HWCs in Uttarakhand. Om and I've had the privilege to work with you. Maybe just share to the group what you're doing on smart HWCs, but also more broadly as you hear the conversation.
So first of all, I'd like to go just for a few moments back to what CEFIT is doing. So, ladies and gentlemen, the Prime Minister's favorite program right now is to get rid of TB by 2025. And in which, as you heard correctly during COVID days, it is test, track and treat. So test comes first, And Cepheid has made an instrument which we all have been using, more than 1,400 labs in India for quite some time. And it is a very compact instrument which can do TB PCR test and also give you sensitivity to rifampicin. So this was really a path breaker when it came in, and I am glad it came in. The only problem was, as always with India, was the cost. And the cost was, at that point of time, say his predecessors, we had a lot of consultations with them, so they were able to bring down the cost. But then our rupee kept on depreciating, and the duties, and you'd be shocked to hear that the government of India still charges about 28 to 30% duty on imported reagents for TB, in which every 1.5 minutes or nearly 1 minute, one patient is dying from that. So there is a disconnect, and I am so happy. And he's joined the top Fortune 500 companies in India. Out of those, the first 100 companies have got R&D in India, so it is never a day too late. And thank you, Dheeraj, for bringing all this. And I've been telling the same thing to the Vacutainer company, BD also, that why don't you think of India as a processing hub? But anyway, thank you very much. So talking about NCDs. Talking about NCDs, so the background of NCDs, which most of you would know, but I'd still repeat because it's the most important thing. So 70% of deaths globally are occurring because of non-communicable diseases, which consists of diabetes, high blood pressure, cardiac diseases, cancer, liver, kidney, lungs, strokes, etc. So there's hardly anything left. So 70% of deaths globally, and nearly 65% of deaths in India, or nearly 60 lakh people are dying from NCDs in India every year. I don't think that there's any family in India which does not have at least one patient of what I have mentioned. So diabetics, which is our favorite disease in India, and those diabetics are twice likely to die of or get a heart disease. And India is also infamously called the diabetic capital of the world. And we are on record. The records are available for you to go through. 10 crore diabetics and about 13 crore pre-diabetics. So how do you take care of pre-diabetics? Because a pre-diabetic person is going to become diabetic one day. So that's a question mark. And further, according to the ICMR estimates, there are over 31 crore Indians suffering from high blood pressure. And 21 crore people of these have got bad lipids, cholesterol, etc., or LDL cholesterol, which, just to tell you, now the Indian, Association for Lipids has brought down the normal level of LDL cholesterol to 70. It used to be 130 when I started testing, then it was brought down to 100, now it's 70. And anyway, so and 25 crore people in India are also obese. So the government service also found that 42% of diabetics and 56% of hypertensive patients don't know that they have these diseases. So we are tackling, really, a kind of a pandemic here. So national program for the NCDs, which the government has recognized and started very early. So this was known as the NPCDCS, and now it's been changed. The name has been changed to the National Program for NCDs. So NCDs. Little changes with the change of name, but well, that's what it is. So the foundation of the program, which is of this program, is population-based screening for everyone who is above the age of 30 years, which consists of a screening checklist. And there's a random blood sugar also involved. There's a blood pressure measurement for good cause, and visual examination of the oral cavity, because oral cancer is quite prevalent in India. Physical breast examination and visual inspection of the cervix using the acetic acid method. So what we recommend, from after having worked with Government of India for quite some time, so they are the number one killer disease, the the cardiovascular diseases that you have already understood. So the cholesterol testing in the national program is missing. So this must be introduced immediately. You don't have to be a rocket scientist to include cholesterol in national program for NCDs. And we have been able to achieve this in our Smart HWC program in Uttarakhand through a hub and spoke model for essential diagnostics, where samples are collected from the community health officers, CHOs in the field, or at HWCs in barcoded tubes transported and tested in the PHC hubs, and labs are sent to CHOs electronically via lab information management system, which we help to install there. So we also need to identify the 13 crore people who are pre-diabetic. How do we do that? And stop them from progressing into diabetes. Currently, there is no mechanism for management of pre-diabetics. Then for screening of cancers, we need to scale up successful point of care innovations like thermal screening, what was just mentioned here. So that's a very good screening method, and on a Indian level, sir, we must introduce it. And sophisticated point of care testing for HPV screening also. How long can you keep on doing the acetic acid method for cancer of the cervix? So further, there is a need to strengthen the continuum of care for those who are suffering from NCDs. And there has to be a referral mechanism where CHOs can facilitate the patient to get a proper consultation with a specialist doctor. This you've all heard about, but it is still lacking. Put on patient treatment course, counsel for the patient condition, etc. Lifestyle, practices have to be told how to improve, because these are all lifestyle diseases. NCDs are lifestyle diseases. And the importance of regular follow-ups and monitoring. I would also like to propose in front of this august audience that we also have a weekly NCD day at all health and wellness centers. Like we have a Wednesday for the ANC day, that is antenatal care day. This day will be dedicated to the NCD patients, and just like 4 ANC visits in their course of pregnancy are mandatory, through this dedicated day, we can ensure at least 4 NCD visits every year. I think that will go a long way. There should also be an annual NCD day on the same lines as World Health Day, World Heart Day, and so many other days. And I think because this is the problem which we all have to, confront with. So if implemented well, these suggestions can significantly bring down the burden of NCDs and also prevent a 2% GDP loss to India every year. So that is where the things start. And the rest I can go through where the digital technology, is very useful, but not being implemented for various reasons. India is not a developed country, please remember that. So the smartness of the smart HWC centers come from the digital, backup. And telemedicine, where community health workers or CHO facilitate patient consultation with doctors, as I just told you. So that is, also recommended, but it must be put into action. So implementation of the hub and spoke model for the essential diagnostics model. I don't want to speak too much about diagnostics because I'm from that field, but it is, please remember, it is test, treat, and track and treat. So if there is no testing, there's a child having high fever in the rural areas, and the mother takes him, so there is a gunshot therapy which is being given by an RMP, and I call it 5 C's: crocin, chloromycetin, chloroquine, cortisone, amritdhara, and the 5th one is cold compresses. The fever is 102 or 103. So how do you bring this, the practices? You can only do it by diagnostics. The point of care diagnostics to diagnose TB. By the way, their TB test takes just 2 hours. And, typhoid, malaria tests are all available. So that will go a long way. So then, of course, we also have to have the lab information systems ready in these places, which is part of the digital world. And then comes a very important part, which is overlooked very often, and that is the training of the staff. If you don't have trained staff in these areas or health wellness centers, So they'll not be, smart HWCs. So our foundation, that is ALVL Foundation, with partner with Eco India, I wonder if you've heard of this organization, one of the largest mentoring programs or platforms for healthcare, to develop and implement an extensive training program for CHOs, that is community health officers, on a comprehensive primary healthcare. The trainings are imparted in a hybrid mode, with some sessions held online and a few sessions held in the physical format. And I'm glad to, share with you that our trainer is right here. Dr. Neelam Tripathi, would you just stand for a moment and introduce yourself or see her? So she is the one who's doing the physical part of the training. And the hybrid training, the virtual part will be taken over by ECHO successfully, because this is very important. And it is at no cost to the government, sir. So this is the training of ECHO is coming out with the iECHO, which is a digital platform that brings together the trainees and the trainers and acts as a single source and maintains all the records, etc. So the electronic records are very, very important. And now let's come to the bad news, that is the bottlenecks. So the bottlenecks are truly, after having worked in the field for nearly 2 years now, is the infrastructure and the absence of high-speed internet. I see if you go to Uttarakhand, you will see an orange cable, you will see a blue cable, you'll see a black cable, all carrying optical fiber internet, but the last mile connectivity is not there. So, and also the proper IT hardware at these HWC centers. We provide whatever we can, but as you know, it's not we don't want it to be a pilot project. And here, in the true collaborative sense of the word, so you've heard of build, operate, and transfer. In our case, it is collaborate, operate, and transfer. So we are not going to be running, these HWCs for forever. So the idea is to show that in a particular geography or a particular area and let the government feel for itself. We are partners there. We have not taken over these centers. So they are running with our collaboration and they are very happy with it. And if it can work in a particular area in Uttarakhand, why can't it run anywhere else in India? And the another point which has already been mentioned by Dr. Mahajan is the lack of integration and the interoperability, which I'm sure will come, gradually. So in a nutshell, this is what we have to say from our side, being partners of the government in these HWCs.
Thank you, Dr. Lal. You're extremely comprehensive and lots of great suggestions there. Do we have time for questions or? Yeah, we do? Excellent. So, Om, we can hear you.
This is actually a suggestion to NHA. I'm not sure whether healthcare industry is fully aware about the implication of Personal Data Protection Act, which has just come. As I study this more and more, I find this actually can be a barrier to what ABDM is trying to do, because if you digitize prescription, then you have all kinds of liabilities. So it actually will put the force behind not to digitize. But I also see an opportunity if ABDM actually becomes a sponsor of this particular initiative and help the industry how to digitize. This actually can become a game changer as well. So while I know I'm involved in some conversation with NHA, but my suggestion would be, I don't know who is the right person, but maybe NHA should become a body to champion this particular act for healthcare industry. It's a suggestion. I don't know whether it's possible.
Absolutely, sir. So we are also working with METI to come up with some guidelines which are specifically focused on the healthcare for in this overall scope of the digital data protection.
Thank you.
Yeah, obviously.
Yeah.
Hello, sir. How many health and wellness centers are there today, and how many are operational? How many centers are there, health and wellness centers today, on the ground actually, and working?
Let me answer this. So 1.6 lakh centers are there in the country, which have been upgraded primary health centers, and some have been amalgamated with community health centers, etc. But where the private, organizations come in, and people like Dr. Swati and ourselves, we can't go to everywhere. So we are collaborating with the Uttarakhand government in 50 of them. So that is a sizable area which is around the district of Uttarakhand. And once the smartness of these smart HWCs is noticed, which has already been noticed, well, we hope and pray that the government will take on itself, because there's no rocket science, which we are doing.
So, sir, what is the difference between the normal PHC and health and wellness center? What is the difference, basic difference?
The normal PHC, you see, the government of India has prepared a very comprehensive list, and they have, hardly missed out on any point. So it was, very foolish for people like us and Dr. Mahajan, to go and, reinvent the wheel again. What we can do is, with our expertise of so-called smartness in, our private healthcare, so we have tried to incorporate all those better management schemes, and telling the government, the idea was first to, get the confidence of the government. And for the first time, they found that here's a PPP in which a private player is not, interested in getting any money. So there's a PPP in reverse. So that they are appreciating, and for example, if there are 10 posts which have been, sanctioned, and only 6 are there, so we bring it to their notice. Then we find out who's the person who can, get these people on the ground, and so on and so forth.
Sir, if I may just add, in terms of difference, since you asked, sir, so basically, I just want to make a clarification. Partners like PATH provide assistance to Government of India. It's not something that partners have designed. So health and wellness centers are very much a part of Aayushman Bharat, which is a Government of India flagship, conceptualized, rolled out, and kind of implemented by Government of India. Partners only support. So the basic concept here was health and wellness centers are different in 2 major ways, if I may say. One was initially most of our primary healthcare. When I say primary healthcare, means sub-centers, primary health centers in the rural settings, and the urban PHCs were mostly RCH focused. Our major service delivery in these primary healthcare settings was either RMNCH services or common communicable diseases. So health and wellness centers are supposed to provide an expanded package of services. We are called, so there are 12 services to be provided. These include the traditional RMNCH services, common communicable diseases, and then non-communicable diseases, emergency and trauma services, palliative care, mental health, oral health. So this expansion of service package to make sure that there is an expanded service delivery available right at the doorsteps of people was first change. Second, it was about a mindset shift. Initially, the focus was only on curative care. Health and wellness centers try to bring in more focus on health promotion and prevention. That's why the name, health and wellness. So this is a mindset shift for Government of India trying to invest in primary healthcare, and this is kind of a deliberate, intentional, intervention to steer the country towards universal health coverage. So that was the basic foundational difference, if I may say so.
I just want to bring to your notice again that it is in the union budget in 2018 that it was announced by Government of India that they want private players to help them out in running of the HWCs. It is not just one day that we got up in the morning and said, let's go to Government of India. It is the Government of India itself. So there is no reason why this should not be a runaway success.
Can I add something, sir?
Sure.
Actually, primary health center is manned by medical officer, while health wellness centers are sub-centers which are converted because sub-centers were previously manned by nurses, A&M. So sub-centers, and these are mainly Ayush doctors, and the RBSK program which came. So these Ayush doctors are trained by, I think there is one course in mid-service level provided under MUHs in Maharashtra, and I think all over India there are courses. So this is a mid-service level provider, and they are supposed to work in the 40-kilometer boundary. So they are not moving out of the thing. So they are the people who will be giving comprehensive, and they are certified by universities for 6 months course. And I think it is happening in the phase-wise manner. So that is the main that health and wellness.
So
thank you.
PM Abhim would be around the 64,000 crores have been put up for this mission for 4 years. And these sub-centers who are now redesignated as health and wellness centers, mindset change is always there, that we need to see the health as wellness centric now, and the scope of services which are being delivered to the health and wellness centers have also improved, and increased. The manpower now is being specifically located on these and designated to this health and wellness centers, and they will be. These are the main changes. Although
just
the
hold it,
facility is the same.
Yeah.
The sub-centers
So
are the
I'll just take a
PSCs.
moment because I think, ma'am, there's a small clarification. Maybe you're speaking from Maharashtra. So just to put things in perspective, health and wellness centers are both sub-centers and primary health centers, urban, rural. Everything is included. It's not only the rural centers. But what ma'am said is right. For the sub-centers, there was introduction of this mid-level health provider cadre that's called the community health officers. However, who the community health officer is a state prerogative. In some states, these are GNMs. In some states, these are BSc nursings. In some states, these are Ayush doctors. In some states like Jammu Kashmir, there is an exception and they've been even allowed to engage Unani doctors as the mid-level health providers or the community health officers. I think this is on the availability of the cadre that they can train. So initially when the program started, the idea was to give them an additional 6 months training on primary healthcare protocols. And this course was designed by IGNU, and that was called the certificate course in community health. However, over a period of time, we saw that this would be a barrier to the scale up that the government was envisaging, because when this was rolled out over 5 years from 2018 to 23, there were targets every year to be achieved. So that's when the government of India worked with the Indian Nursing Council to integrate this 6 months course, whatever the additional components were, in the BSc nursing curriculum itself. So all the nurses that were then passing out from the last couple of years are already trained, and they don't need this additional 6 months training, so they can be screened and they can be deputed. But the process varies from state to state. Maharashtra has already kind of taken a co-adopted their existing BAMS doctors or the Ayush doctors that they had and put them as community health officers, but it differs from state to state.
Swati, thank you. We'll take 2 more questions. I know Dr. Mahajan's got a panel after this. So we'll take a question here and then...
Very quick question to Dr. Akshay.
We'll just take a question here. We'll come to you.
Regarding this ABDM, again, I think the primary objective is the personal health record. And we've done this e-grid system with Maharashtra, and we realize that unfortunately there is no data which comes into this primary health record. Because whenever a patient travels from one to another, when you go back to some of these medical colleges, they show 250 patients outside, and other than some images, a bit of rudimentary lab report, there is nothing at all. So I think the objective is good, the challenges are many, but then if we don't fix this personal health record information which they need to carry, which is going to be most meaningful, it will not meet that objective.
Thank you. Thank you.
Sir,
go ahead. Go for it if you...
So primary health record, I think you are alluding to the mobile phone application on which people are carrying the records. It depends upon what kind of solution people are using and what kind of back-end technology that they have developed. So technologically what happens that the people create a record, they bundle it, and then the software solution or the mobile phone application has to debundle it. So maybe the ABHA application which we created as a reference application for the ecosystem, people have just copied it. We are thinking that slowly private solutions are more going to come up with more innovative solutions which they will have better quality of the healthcare records which are created. We are following the internationally accepted FHIR standards, and which have 7 different types of the healthcare records which can be bundled and then debundled also. So it depends upon what kind of solutions, but yes, different solutions, when they come up and they innovate more clarity on more detailing of the healthcare records, the imaging records, the prescriptive records, the diagnostic records, all will be there in the...
That's wonderful to hear. Thank you. We'll take one last question here maybe, and then I think we've got a hand up there. We'll come to you. Maybe we'll give you the last question. But keep it short, please.
Yeah, I think your opening remark, Dr. Swati, about challenge of the biggest gap, as you identified, was the process enhancement and delivery, I guess. I think that actually is the crux of the success of any program implementation. So I'm sure the government, of course, work in a standard mode, as you were actually talking between yourself. Don't you think that the private sector, with the expertise of Dr. Arvind Lal and I think the whole panel that is there, should be contributing to revising these protocols in the delivery. Actually, because all of these talk of creating a lot of infra and everything has no meaning till they, as Dr. Sanjeev also pointed out, I think it is the measurable outcome which actually will define the success. So, your comment on this?
No, totally aligned, sir. I think private sector brings in different expertise altogether. Private sector brings in the scale, the expertise, the systems that are well proven, and I'm sure this is not for me to decide, but Government of India definitely must be looking at it. But yes, I definitely align with you, and in a way we are also private, though not for profit, but helping the government. But yes, definitely, and I think there are states, sir, that are open, that are partnering with private partners like Dr. Lal himself mentioned. So I think the change is slowly coming in, but I think there is acceptance now, and there is acceptance. I will just take one moment to define, like we are also helping Government of India to work on a model for supply chain strengthening. The entire health and wellness sector concept also is on reducing the out-of-pocket expenses, and we know that 70% of out-of-pocket expenses in primary care settings are on drugs and diagnostics. So having functional supply chains is very, very important for public health systems to function the way they are supposed to function. So we were requested by Government of India to help them design a pilot for last mile delivery of drugs and diagnostics. And it was specifically a demand that why don't you bring in private sector expertise? So we've actually partnered with Tata 1mg on that one, and we're piloting it in 6 states to see how last mile models which are fit to context can be delivered. So definitely there is that acceptance, sir.
Thank you, Swati. You are the very last question, please.
Yeah.
Please keep it short.
Yeah, I'll be short because there were a couple of challenges raised by the panel. So I just want to draw our attention, especially Ms. Mahajan and Mr. Akshay. There are some globally disruptive, the platform, especially on the communication and the collaboration on healthcare professionals and the clinicians to overcome the challenge of the, the shortage of manpower and all, call it as a clinical WhatsApp. We know that how WhatsApp has created a disruption in day-to-day communication, but there is nothing secure regulated platform for, especially for the healthcare professionals, which can pool in the capacity of the clinicians across the primary healthcare, the sphere, and giving them the access of taking, the information on an instant basis to take the care decision and helping in the entire, the referral pathway. So this has really disrupted the UK NHS hospital scenarios in improving the clinical efficiency by more than 70%. So would love to have a more discussion around that.
So we are very open to all kind of disruptive technologies coming from every kind of player, whether private or government. So we only want that every kind of system or every kind of solution is more than welcome to come and integrate with the Aayushman Bharat digital mission. It's a mission where we are working and we are harping on interoperability of one system to another. So these systems or communication systems can work with the HMIS systems or the hospital management information system seamlessly also. So we are completely aligned with the different kinds of solution if they integrate with and they follow the same standards and protocol which you said.
And also the data protection part, what just doctor has said, because that is most important because you are dealing with the patient sensitive information.
Data protection, I want to say that when we read the act which is now is more principalistic act. So when we read the act, we saw it completely aligned with what blueprint we had in 2018. So we have privacy net, we have consent manager already installed. We are catering to consent. We are catering to how data should be stored and how we already follow the federated data architecture. We are already putting that data should be stored where the data was created, and the storage guidelines are now commonly governed by the Data Protection Act. So it is completely aligned with what ABDM is. Now, whether you want it or not, the digital data which people create has to be stored as per the digital data protection.
And that's where this platform is also, the data
I think
secure.
we'll wrap.
Yeah,
I think
so
we'll wrap there. Thank you very much.
Sure.
I just want to close the panel. Extremely rich set of topics, issues that I think we've talked through in the last hour and a half. I leave extremely optimistic actually and encouraged over the amount of experimentation and activity that is happening in different spheres. But I think the key really, as someone said earlier, is about collaboration and multi-stakeholders coming together to really move forward. But a big thanks to a phenomenal panelists who have been very insightful, I think, today in sharing some really terrific perspectives. So thank you very much. We have Dr. Mahajan on a very exciting panel next. So some free advertising there, and please stay.
Thank you very much, the panelists and moderator, for sharing innovative solutions, data-driven approaches, collaborations between the stakeholders, which are important for a better health outcome. We assemble back for the next event, that is the next session, that is Perspectives on Healthcare, and we take a break of only 20 minutes. Thank you. Ladies and gentlemen, I request you to kindly take up your seats, please. Welcome, sir. Yes. If there are students, delegates, I request you to kindly move towards the next room. We have made necessary arrangements there. Thank you. A very warm welcome to each one of you. Please help me welcome Dr. Vinod K. Paul, Honorable Member, Niti Aayog, Government of India. Can we extend a big round of applause, please? Thank you very much, sir, for joining us. This session is on perspectives on healthcare. And Sir will be chairing the session, and we have the convener and moderator, Dr. Harsh Mahajan, Chair Ficci Health Services Committee and Founder-in-Chief Radiologist, Mahajan Imaging and Labs. We have very eminent speakers from the industry, Mr. V.K. Shunglu, Chairman, DPS Society, Dr. Welcome, sir. Dr. Jyotsna Suri, Past President, Ficci, and Chairperson and Managing Director, Bharat Hotels Limited. We have with us Mr. Shekhar Gupta, Editor-in-Chief and Chairman, The Print. Welcome, sir. Also, we have Ms. Ritika Pandey, Associate Vice President, IPE Global. Welcome. And Dr. Dharminder Nagar, MD, Paras Health. Thank you. I, with complete humbleness, request Dr. Harsh Mahajan to hand over the green certificate to Dr. Vinod K. Paul. Thank you very much, sir. And I now request Dr. Harsh Mahajan to take the session further. Thank you.
Thank you very much. Good afternoon. I think we are in for a great time, a great session. Perspectives on healthcare. The healthcare industry, as we all know, is complex, multifaceted, requires innovative solutions to address its challenges effectively. The significance of perspectives on healthcare from other sectors cannot be overstated. We need to learn from them. These perspectives can offer fresh approaches and disruptive thinking that can catalyze transformative change in our healthcare sector. External viewpoints can enable the healthcare sector to draw inspiration and lessons from other industries, fostering a dynamic and adaptable healthcare ecosystem that can better serve the needs of patients and improve overall healthcare outcomes. The session aims to bring together renowned speakers from various industries to share their unique perspectives and valuable insights on the healthcare sector, and for us to determine what we can actually learn from them, the problems they faced, are they common amongst different industries? It is indeed an honor for Ficci. This is something I wrote to the panelists. It is indeed an honor for Ficci and personally for I that all of these stalwarts have accepted our invitation to share their wisdom and experience on this quite unique panel. The healthcare sector, as I said, can learn much from other sectors of industry. And we want a free and frank discussion. The discussion would be interactive and freewheeling, so any one of the panelists can add, can interject. Of course, let's not be like some of the shows that we see on television, but let it be free and frank. Please don't hold back any punches. Criticize where due and praise if you think the healthcare industry has done well. And do certainly advise us on how we can do things better. We have an enlightened audience which is there to listen to your thoughts and perspectives. And I hope to have them join in the conversation in the latter part of our panel discussion. We have tried to bring together the best of different fields onto one stage, and I'm sure the learnings from this discussion would make healthcare delivery better in our country and help in overcoming some of the challenges and problems that we face. Health is wealth is an old adage, and nothing brought home this truth better than the devastating COVID pandemic. Hence, this session is a very important one in the two-day Ficci Heal conference, whose theme is healthcare metamorphosis, and we hope that the discussion here would help in fostering better healthcare. We have on the panel Professor V.K. Paul, a dear friend, a mentor for over 30 years, who has actually been responsible for transformative change that has happened in the last 6-8 years in healthcare in this country, the new vision, the outreach, the emphasis on access, the emphasis on technology, and we've seen how things have changed. Dr. Paul wants to speak at the end, but sir, a few words in the beginning based on the kind of interactive discussion from different fields that we are going to have. Over to you, sir.
Thank you, Dr. Mahajan. Esteemed Shri V.K. Shungluji, Dr. Jyosna Suriji, Shri Shekhar Gupta ji, whom I admire immensely, Dr. Dharmender Nagar Sahab, Ms. Ritika Pandey ji, and the leadership of India's industry and commerce. I'm so honored to be here. Ficci is, as an organization, is etched in my memory since childhood. It's very special. Don't want to miss any opportunity to be able to reach out, to interact, and to learn from. The panel is focusing on a very important and a timely topic, very important. As we are moving out of the stress and the devastation that we all experienced during the pandemic, we are looking we have set our sights on 2047. We are in Amrit Kal. There is a new thinking, new ways of looking at things, accelerating what's good, correcting the gaps in a very holistic manner. To me, it is a very timely opportunity, and I want to learn from our esteemed panelists and from the interaction. And I would therefore choose my option to speak in the end and give my reflections at that time. But I'm looking forward to really, new ideas, new thoughts, and a new way to move forward. Thank you. Over to you, sir.
Thank you very much, sir. Thank you very much. And let me start with Dr. Dharmender Nagar, a young doctor who came back from England. His family was in a different kind of business. We all know Paris Milk. And starting from one hospital in Gurgaon to now going into tier 2 and also, as he said, tier 3 cities of the country. Dharminder, share with us your journey and how did probably the learnings from your parent industry or from your parents' industry help in making you reach where you have. Recently, only 2 days ago, I was in Srinagar and I was glad to see, a Paras hospital board there right in the heart of town. So take us through your journey, the learnings, which may help others also to do the same.
Good morning, everyone. Thank you, sir, for the privilege of having me participate in this panel discussion. I think this is one of the finest panel I've ever seen, and Dr. Harsh Mahajan deserves a great applause for putting this together. You asked me the question that what has been the learning from my family to me and what has been my journey. The great learning I had from my family was that we come from a very rural background. My father was a self-made man who never got education, but made sure that each of his children got education. He said कि अगर खेती भी करनी है, अगर गड्ढा भी खोदना है, make sure you have a degree in hand, then only I'll allow you to do anything. Practicing medicine in England was not the best thing for me. I had never any empathy or sympathy for Goras. I thought कि यार मैं अपना टाइम क्यों खराब कर रहा हूँ? गोरों की सेवा करनी है तो डॉक्टर क्यों बना? पिताजी के पास पैसे तो ठीक ठाक ही थे. I don't have to do this. That was the insight I had, that I don't have to do this. Karna kya hai, that never got through to me. So I spent next few years wasting my time, whiling away my time. एक आध डिग्री भी ले ली कि भाई इंपीरियल कॉलेज भी चले जाओ, डिग्री तो ले ले. पेरेंट्स कहेंगे that you did do nothing in England, what have you done? Anyways, coming back, how does this translate into my mission vision? So you all might think when I opened in Gurgaon that Gurgaon is a cosmopolitan place and stuff like that. When I opened in Gurgaon, there was not a single hospital in Gurgaon. The biggest hospital was 50 beds. In fact, everybody said the Gurgaon doesn't need a hospital more than 100 beds. That is, in fact, one of the big 4 consultancy companies' report that I read. And I thought, I am screwed. These padha likha people are saying the no more than 100 beds. The values I got of my family, that you don't only have to serve the rich. Unfortunately, I could not afford to serve only the poor. वो तो गवर्नमेंट भी नहीं अफोर्ड कर पाती है. मेरी तो औकात क्या थी? That leaves with middle. I had always had this ambition to serve the middle. I also had this ambition कि I come from a rural background. I have been privileged to study, educated, and have financial security. तो काम करना है, so I had to make a change. How do I make that change? Within the bounds of healthcare, within the bounds of commercial healthcare. I'm trying to solve for access. My second biggest project was in Bihar. Again, there was no proper hospital, corporate hospital, big size hospital in the private sector in Bihar. Just one simple statistic, between NCR and Kolkata in 2012-13, we were the first PET scanner in the entire population between that belt. Can you imagine size of Europe having one PET scan? Things have changed tremendously since then. आज मैं दरभंगा गया हूँ, रांची, and Srinagar. I must confess, Srinagar, Ma'am Suri is sitting here. She is one of the pioneers in investments in that state. But I was clear, every state you go in North India, there is an issue of quality healthcare access. Affordability से ज़्यादा quality access का issue है. Kashmir has tremendous amount of access issues. We just opened few months ago. The decision of the governments has helped us expedite the matter. And it has been tremendously helpful. The government in Jammu and Kashmir has been tremendously helpful in organizing a large-scale hospital, because everything they are learning from scratch. There's nothing in the private sector. So to cut short my long-winded answer, sir, what I've inherited is the values. What I've inherited is the mission. and what I've inherited, maybe in all of this, a commercial successful organization भी कैसे चलानी है. That is what I've inherited. Thank you, sir.
Thank you, thank you very much, Dharmendra, and also for saying that the middle can still be viable, can still be profitable, and you can go to the smaller towns. And we were having a conversation before this where he said that the land in Darbhanga per square meter is more expensive than the land in Gurgaon, which was very, very surprising. So this thought process that all of us have, that you go to tier 2, you go to tier 3, things are cheaper, that may not be right. He also shared that he has to pay 30% more as salaries to the top doctors than what he pays in Gurgaon. So this is something which most of us may not be aware of. Thank you, Dharmendra. And now we have a very senior bureaucrat, the former CAG of India, and for the last 10 years, the chairman of the DPS Society, which runs some of the finest private schools in the country. I have studied in the first one when there was only one, and there are over 200 Delhi public schools around the country now. Sir, what are your thoughts? Because teaching, learning, skilling is very much a part of what healthcare does, what healthcare needs. What would you advise? Is there any learning there for the healthcare sector?
Thank you, Dr. Mahajan, for calling me and saying all these kind words. Firstly, I'm quite confident that everyone sitting in the audience is either a parent or a grandparent of a child who's in school today. And the profile of those who are in school today has changed very, very dramatically. One, they are coming to school at a much younger age. Two, they are staying for a longer time. With new education policy and so on, they'll be staying there till about between 18 and 19. And when I was in college, we were, more or less planning to pass out of BA by that age. 19, I passed out of BA at 19. And here we have children so-called children at 18 and 19 who are in school. We very firmly believe in co-education. All our schools are co-education. So that managing children with that kind of needs, who are virtually on the threshold of adulthood, and they all need a hell of a lot of counseling. So one big issue in education today, counseling. But connected with that is, at some level, the parent expects everything. At another level, if, for example, I was to go in for a medical examination for students, I would be lynched. How dared you take the weight of my child? Who are you to say he is overweight? क्या खाता है आपसे क्या मतलब है? And the result is that earlier we could very well manage with a small dispensary, maybe a nurse now and then. Now we have to have a fully equipped medical van standing there all the time. And so someone ate some food, started choking, If we call the ambulance, he'll be dead. So you have to send your ambulance, and so then there is this again the moral issue. How far can we go with a child, and how far we are restrained from doing? Third thing is when, for better or worse, and I'm not making any value judgments here. But let us say up to the year about, if I remember correctly, 2007 or 2008, somewhere around that, I'm not sure. There was some kind of screening when children were admitted to school. I'm not here to say whether it was right or wrong, but now the policy is that anybody who is in the neighborhood must be admitted to a school. Very good. Everyone is admitted, but in that admission, I can't really place a percentage, but certainly half to 1% children have learning disability. How do you identify that? Does any parent acknowledge it? आपको कुछ नहीं मालूम, हमारा बच्चा ठीक है, आपके टीचर ने ठीक से नहीं पढ़ाया. So this is another big thing which has changed, that the children have all kinds of ailments. I don't say that children who have disability shouldn't study. In fact, we have sections for children with disability. But certainly they have to be placed with like children. Second, there is a point beyond which, if there is disability, they have to go to a special school. But today there is no system for that. Nobody acknowledges that, by identifying those people who have special needs, you are not actually doing a service, you are told you are doing a disservice. Mere bacche ko bata diya. That kind of comment. So that's another problem which is increasingly faced. Third kind of problem which comes up is that at least when I was in school or whatever, maybe talking of ancient Indian history, whatever, the fact is that many of the diseases which come up with children didn't exist. Nobody said कि ये बच्चा heart attack से मर गया. Oh, no question about it. But even that kind of ailment, there is a potential for that in people at a much, much younger age. So with this kind of clientele with whom we deal, we need the closest cooperation with the healthcare people. So every school is connected to a hospital. But arguably that connection is only when there is a problem. That connection is not to guarantee that the normal health and well-being of the child, whether physical or mental, is preserved. Because even today, there is a huge resistance to any kind of medical by the school. You just can't do it. So it's important. You can't tell the parent, "Kar ke le aao," who are you? So you have all these problems in school. You are required to deal with it. You tie up with the health sector, but even they are helpless, because what can they do? If the facilities are there and the structure is such that the problem which exists cannot be resolved by the kind of authority or interrelationship or whatever exists. So this is another very big issue, what to do with. By and large, even COVID, we faced that problem. COVID has resulted in lots and lots of mental strain. So the children who not necessarily contracted COVID, but who went through that period have developed serious learning disability. And, there are no short fixes, kisko tuition de do, theek ho jayega. Doesn't work like that. So, whenever there is this kind of big issue, I don't know how can the three players in this, the parent, the health provider and the school, how can they come together so that we at least have some manner in which we can address it? And so I'm not saying that any of these problems are insoluble, but all I'm saying is solutions today are ad hoc. They depend very much on the person on the spot. And, when I get up, I pray that all my people who are dealing with it are taking the correct decisions. Otherwise, you can have a crisis at any time. Not much else to add. Thank you.
Thank you very much, sir, for these perspectives. And we have one of the best pediatricians of the country sitting here. And I'm sure these words and the problems that you've highlighted, maybe there would be a way of getting these three, together through some kind of policy, so that I do know that schools feel very fearful about a child falling sick, and maybe this interaction will lead to some action which will safeguard not only the child but also the managements of schools, because most of these are altruistic activities. Everyone is doing honorary work, and for that to be able to face some legal issue going forward is quite a nightmare. Thank you for your insights. And now over to one of the doyens of the hotel industry, past president of Ficci 2014-15, if I'm not wrong, and who has actually brought tourism and the hotel industry, transformed it with her own grit and with her own vision. The hotel industry, hospitality, and hospitals, a lot of what we do in hospitals, in inpatient care, is hospitality. So what can we learn from you, ma'am? And what are the challenges that you face which may be similar to what we face in the healthcare industry?
So, namaskar everyone, and thank you so much, Harsh, for having me here. I have a doctor as a prefix, but I'm really an honorary doctor of laws, which was conferred to me by the University of Warwick for my contribution to tourism in India. Yes, there's a lot in common. As a matter of fact, we were having a sort of a discussion before as well. We are almost in the similar sort of situation where we are serving people. I mean, the first and most important thing is that we are serving, and we are serving people. And in our industry, which is the hospitality industry and the hospitals, it is about people who are serving people. So while we take advantage of robotics and we take advantage of machinery, but ultimately it's that nurse or the nursing aide or the general the upkeep of the hospital. All of that is done by people. So one common factor is that it is both our industries are where people serve people. So that brings us to the question of human resource. I mean, where do we get these resources from? Skilling becomes an important issue. We just heard from Dharmender that he has to pay almost 30% more to get his doctors to go to a remote place. But we face similar situations as well, because as you expand out and you are not only in the metros, so metros are of course perfectly fine, but hospitals and hotels need to be all over the country. So you go into some remote places. For example, we have a lovely hotel in Khajuraho, and there isn't a hospital nearby at all. So if somebody falls sick, the nearest place is perhaps Chhatarpur, where you have to drive maybe 2 hours, 3 hours, 4 hours, sometimes back-breaking. So hospitals and hotels, they kind of have to coexist with each other. Yes, manpower is another issue that we all face, and skilling becomes extremely important. I think we need to have more and more colleges for the hospitals, for training, and of course for hospitality as well. I think another issue, now that you're asking about what are our common issues and challenges, if I can just focus on another issue, and that is land. We were also having a brief discussion on that. Now, we were talking about private players, and we do need to expand hospitals into private hands. So the biggest challenge that comes our way is land. And if we have to buy, I mean, hotels also buy land at commercial value, and if hospitals also have to buy land at commercial value, then it becomes an unviable project altogether, because that is the biggest expense that all of us have. Then, of course, the infrastructure has to be created, but that is pretty much the same across for any construction. The big challenge that comes our way, and what is the biggest deterrent of people going further and further into remoter places, or even the metros, for example, or even the bigger tier 2 cities, for example, is the lack of land. So here, I think the government has to come forward, and I know that both hospitality and hospitals and have been trying to get that infrastructure industry status. So having an industry status, I mean, as a hospitality industry, we have, some states have given us an industry status, but what we need is a unified infrastructure industry status. What does that do to us? It gives us land at a very, very reasonable cost, even leased out land, but of course has to be well located. It gives us water, electricity, and the other basic amenities that we need. Otherwise, we are all paying very high commercial rates. And I know hospitals are also paying a very high commercial rate. Now, that actually brings your return of investment to a much fewer numbers of years. And the viability becomes easy. So we need to now work together and see how we can actually get that industry infrastructure status, and it has to be unified across the entire country for us to be able to actually sustain and develop and grow. We can't stop, and I think Shekhar was pointing out as well that whether it's education, whether it's schools, or whether it's hotels, or whether it's hospitals, we can't stop developing. We have to, because this country is huge. The demographics are to our advantage. So we all need to continue to develop. But if there is a conducive environment, and particularly the viability of the investment, it just makes it much easier. I also want to compliment the hospitals before I close. There's a huge transformation in the service levels that are coming in the hospitals, and I'm talking about a lot of the private hospitals. I'm very happy that hospitals have learned from the hospitality industry, and the kind of service that you get in a hospital room is by no means any less than what you will get in a hotel. And by the way, on an aside, your rates, some of your rates were much higher than our hotel rates. So, well, I mean, so it was what it was, but happy to and compliment all of you who are in the hospital business, that you have actually learned a lot from the hospitality and your service and your housekeeping, just your general interaction with people. Has really been good. By the way, we lost a lot of people to hospitals, and that matter as well. But all in all, I think yes, we are blessed with a huge country. We are blessed with a good government in place at the moment. They can take decisions. The demographics are to our advantage. We have the demand and supply all within this. We don't need to import anything. We can do it for ourselves. We have some of the finest brains, some of the finest doctors in place. And nobody needs to teach us hospitality because we can do it better than anybody else. So I would say that if we got a conducive environment, and this is where I'm going to, turn towards you, Vinodji, is that if the industry infrastructure status is granted to both healthcare and hotels, I have to plug in the hotels as well, the development would be a lot easier, and the return of investment would be so good, so much better. Thank you so much for listening.
Thank you very much, Jyotsna ji. Those were really deep insights, and the parallels that you draw between the hospitality and the hospital industry, I mean, that's fascinating. Also, I may tell you that just as probably your industry has been after the government for grant of infrastructure status, similarly, the healthcare industry has been very persistently pursuing the government, but somehow I think the task now falls upon Dr. Paul to see that this happens, because just as the hospitality industry, similarly the hospitals are willing to go to tier 2, tier 3 towns, to rural areas, but it just doesn't make economic sense, because of which no one is willing to fund, and that's been a constraint, and I'm sure Dr. Paul will wave a wand, find some method of making it possible.
Hands together.
We should, I think. And now to someone whom we all know, whom we all see, whom we all admire, so many fans of yours in the audience, Shekhar. You are someone who can give a 360 view, probably an unbiased view, an outsider's view into what you think about the healthcare industry. What do you think about the way we are providing diagnostics and treatment, the way health education is happening? Just give us your insights and maybe some thoughts, advice on how to do things differently, better. I do know the government does listen to you. I'm told they do see your program, and I would also request you that you must bring this up in one of your talks, which you do, which is always deeply researched and given very, very unemotionally. Over to you, Shekhar.
Well, thank you. First of all, I plead not guilty to the charge that the government listens to me, right? If anybody thinks that the government listens to everybody except itself and the voter, that person is living in cloud cuckoo land, and I am not. So we do our thing. Governments don't listen to journalists. Almost no government listens to journalists. The only government that listened to journalists was VP Singh's, which lasted 10 months, right? Only governments on daily wages listen to journalists, because journalists become their hangers-on. And then they're advising, isko bana do, usko hata do. So that's a very different. So let me get out of it. I will just speak. I have no qualification to be on this panel. The only qualification I have is that Harsh and I have been neighbors for more than 3 decades. So I am here. So I will give you, since he said 360 degrees, I have a bugbear, and that bugbear is that India is a growing society. It's a growing society, a growing economy, and we have used the word aspirational now for 15 years. But aspiration has arrived. A society does not remain as only aspirational. When a society becomes aspirational and as aspirations can't be met, the society gets angry and frustrated. So if you travel around the country, smaller towns particularly, villages still, because the expectations from government were minimal, so they are getting free ration, they are getting some money in the bank, PM Kisan Samman, they are getting some money to build another pakka room in their homes, a toilet. Small towns, frustration and anger and just underemployment, and that is one part of the frustration, and that also comes from the same problem as people's frustration with indifferent healthcare, indifferent or very expensive healthcare. There is a lot of data that suggests that maybe some 30-40 crore Indians who are today technically above the poverty line, multidimensional poverty, not old-fashioned. Multidimensional is a much wider definition. 30-40 crores will drop below the poverty line immediately as somebody in their family is sick enough to require hospitalization. So there are issues in the country. Now, most of the issues as of underemployment in small towns and rural India, these come from undersupply. There is undersupply of everything which traditionally the government was meant to supply. So there is undersupply of good quality school education. There is total undersupply of good quality college education. College education is a disaster in our country, and I'll come to the other side of the impact of that. And there is undersupply of medical education, nursing education, and public health care. Now, there's been a debate for a long time, and I've argued with many successive health secretaries who were intrinsically and ideologically against the idea of private healthcare, because they said, what is private hospitals? They have 5-star hotels, they charge so much money, they pay doctors so much salaries, they're taking our best doctors from AIMS. To which I would say, but not everybody is leaving AIMS. Look at Dr. Paul. He didn't leave AIMS. So I also know doctors, people make their decisions. I also know senior AIMS doctors who say, मैं छोड़ के तो चला गया, salary बहुत बढ़ गई, लेकिन मेरे students कहाँ पर हैं? So there is a role that public healthcare plays, but at the same time, private healthcare is also needed. So it's not either or. It's an old ideological argument. So all of Bihar is lying in darkness. Gurgaon's malls are glittering 24/7. To which my counter argument used to be, is Bihar living in darkness because Gurgaon's malls are glittering? No. Bihar's living is darkness because Bihar's leaders successively have decided to keep it that way. Including the current one, who's been chief minister under everybody, in partnership with everybody. So BJP, Congress, RJD, all of them are guilty of having countenanced what he's doing to that state. But because Bihar is in a bad state, doesn't mean that you can't have Gurgaon or you can't have Bangalore. So same thing applies to education and healthcare. Much more than hospitality and healthcare, I draw a parallel between education and healthcare. And what happens, I just saw this film which will be releasing today formally called 12th Fail. Vidhu Vinod Chopra has made that film. So that film, besides everything else, it's about somebody who comes from a village in Chambal, Hindi medium. His school and college have educated him for nothing. So he comes with a plain BA 3rd division or something to Delhi, to Mukherjee Nagar, at these colleges, at these coaching centers. And then this whole story of the coaching center and how the coaching centers exploit you, how all the coaching centers put up the pictures of the same topper saying, "Hamare yahan bhi aaya tha, hamare yahan bhi aaya tha, hamare yahan bhi aaya tha, hamare yahan bhi aaya tha," because they paid off the toppers, right? So a corruption of young All India Services Officers begins from the day of the result. That said, for a moment I said, how terrible is this? This has become a 36,000 crore industry, this coaching. This should stop. UPSC and others have to change the way they admit people, because this means only those who can spend money on coaching can be successful, and then families like this guy's families have to send their cows, buffaloes, whatever property they have, tractors, to send their kids to Delhi, and they live 6 to 1 in Mukherjee Nagar in one little dormitory. And then, since this was 2 days back, for 2 days I'm thinking that 99% of India, 99, maybe 97% of Indian kids get the same quality of school and college education in public schools and colleges. From there they come into this very competitive world, and then they have to scale up because their teachers have not been attending college. I'll take you to any district college in our country, including next door in Haryana. Teachers never come to teach. Right? Teachers are running pawn shops outside colleges. Teachers never come to teach. Nobody can question a teacher in a government college. Government school में फिर भी आ जाते हैं. Government college में, मैं government college में पढ़ा हुआ हूँ. Government college रोहतक में आज से 50 साल पहले पढ़ा हुआ, 75 तक पढ़ा हुआ हूँ. तब कम से कम टीचर्स आ जाया करते थे. उस कॉलेज में भी मैं वहाँ पे 4 साल पहले, 5 साल पहले प्राइजेस देने गया था. कोई टीचर काम पे नहीं आता है. सब लोग ट्यूशन पढ़ते हैं. सो दिस इज, इफ माई कॉलेज, I can only afford to go to a government college or a government school. That's all what my parents can afford. Or I can only afford to go to a government hospital or a public healthcare facility because I can't go elsewhere. When those don't scale up, certainly both haven't scaled up in the government sector as well as the best doctors are in AIIMS. But how long does it take you to get attention from a doctor in AIIMS? So India has undersupply of good education, good medical education, good nursing education, and good healthcare. So we have to scale up supply both qualitatively and quantitatively. Qualitatively much more in the government sector. Now these are arguments that go on. When Apollo first came in and then Escorts, people said, oh, the rich now go there. What about the poor? And AIIMS has such long lines, and I would then make a counter argument because I instinctively puts myself on the contrarian side. I would give a counter argument saying that, look, when there was only AIIMS in Delhi, that anybody who had connections or anybody whose uncle was somebody or anybody who could call somebody would get time with an AIIMS specialist, whereas the poor would then wait for 6 months. So today, all the well-to-do can go to the private hospitals. So availability to the poor has actually improved. It is not great, but it has improved compared to what it was earlier. So India needs everything. India needs a lot of public education. India needs a lot of public health care. And India also needs a situation whereby the gap does not become so much that the elites secede from India. And I'm not saying that the solution to that is to, like communist countries used to have, put an exit control that before anybody leaves India and you get a visa to go to another country, but you also need a visa from your country to go out. I have traveled in Soviet Union, Afghanistan, East European countries in the times of trouble and war, where you always had that anxiety ki exit visa milega ki nahi. So I don't want that. But the fact is that today, anybody who's well-to-do, any parents who are well-to-do are today mass educating their children in private schools to be sent out for undergraduate education to American universities. That's why presidents of all American universities are floating in India, because none of them is going on a scholarship, because undergrad scholarships are very rare. American universities, British universities, Canadian universities, Australian, Singapore. Today, India's import of undergraduate education is $23 billion. Why is it happening? Because to get into a good public college like St. Stephen's, you need what, 102% marks or something like that, right? So why aren't there 20 St. Stevenses? Why is St. Stephen's not added 3 more floors? Why is capacity not, they cannot add it because they can't charge the fees. So this is all very mixed up in our Indian hypocrisy, which means we'll not scale up sufficiently on the public side. At the same time, we'll keep cursing the private side. The fact is that in India, everything has to go up. Public side has to go up and the private side has to go up. And both will then complement each other. As the private side goes up, more and more richer people will go there, or they will send their children to schools and colleges like that. Otherwise, you will have this division where the rich will now, सारे नए स्कूल शुंगलू साहब जो बन रहे हैं सभी इंटरनेशनल बैकलॉरेट टाइप जो भी कहते हैं वो बन रहे हैं, वो मास प्रोड्यूस कर रहे हैं. आजकल तो सरकार डेटा देती नहीं है किसी को, लेकिन आप डेटा चेक करेंगे तो मैं आपको बता सकता हूँ, क्योंकि मैं सारे स्कूलों में बोलने जाता हूँ, कहीं प्राइजेस देने जाता हूँ, कि जो दिल्ली के 10 एलीट स्कूल हैं, 10 मोस्ट इन डिमांड स्कूल्स हैं, 10 उनके about 90% of class 12 graduates go overseas for undergraduate education. So it's not as if वो सारे suddenly इतने brilliant हो गए कि उनको foreign admission मिल रहे हैं. वो बहुत पैसा लगता है उसके अंदर, और जो वहाँ नहीं जाता है वो अशोका जाता है. इसीलिए तो ये इंडिया में हर जगह ये अंडर सप्लाई है. मेडिकल एजुकेशन में मैसिव अंडर सप्लाई है, और पब्लिक, और क्योंकि मैसिव अंडर सप्लाई है तो जो डॉक्टर पढ़ के आते हैं वो प्राइवेट हॉस्पिटल में जाते हैं. इसलिए जो गवर्नमेंट का सिस्टम है दैट इज बीइंग स्टार्व्ड ऑफ talent right now. It will be when the government scales up. Now so many aims are coming up. It's a fantastic idea. I wish more would come up, but they will be brutal competition for talent. The government will have to compete with the rest. So these are things in India. Unfortunately, these do not become voter issues as much as they should. But the fact is that people not getting school or college education and then coming to Mukherjee Nagar and paying lakhs of rupees every month, basically to relearn or learn what they should have learned in school and college. This is, in conclusion, what is called a broken window economics. तो आप क्या कहते हैं, हमारी इकोनॉमिक ग्रोथ नहीं हो रही, तो आपने अपना पत्थर मार के खिड़की तोड़ दी. अब खिड़की तोड़ दी तो आपको खिड़की नहीं लगवानी पड़ेगी, शीशे वाले की इनकम होगी, लगाने वाले की इनकम होगी, कारपेंटर की इनकम होगी, सबकी इनकम होगी. तो आपने इकोनॉमी को ड्राइव किया ना, जब बन गया फिर तोड़ दो उसको. So a lot of our country, and it comes from the old Congress socialist times, we are a case of broken window economics. That's why हमारे घर में हमने बिजली ठीक नहीं करी, हम बिजली के पैसे नहीं देते, इसलिए हमारे घर में इन्वर्टर है, हमारे घर में सर्वो स्टेबलाइजर है, हमारे घर में अपना जनरेटर है, राइट. तो ये सब कुछ, इस सब की ज़रूरत नहीं है अगर हमारे यहाँ बिजली ठीक से आए. बिजली ठीक से तब आएगी जब हम लोग बिल पे करें. बिल हम पे कैसे करें, हर सरकार मुफ्त बिजली देना चाहती है. सो हमारी जो एजुकेशन और मेडिकल एजुकेशन है उसी सिंड्रोम में फंसी हुई है. एंड दैट्स व्हाई पीपल लाइक डॉक्टर पॉल, we have to be very grateful to people like these who've stayed on in the government system, because each one of them in his specialization he can get 50 times, maybe even more than that, stock options वगैरह सब कुछ मिलेगा if he were to leave AIMS and his modest government salary. So for anything to improve, yes, all of the private sector should bloom and grow, but underlying that, the public facilities, the public availability of education and healthcare, it is very demeaning for the middle class and the poor of India, and that has to be addressed.
Thank you very much, Shekhar. You really did a 360, and education and health both together, and hopefully at some point of time it will become an election agenda. People will be aware and they will vote for that. We did hope about 5 years ago that this was happening, but then again, other things come to the fore. But what I can tell you that in the last 8-9 years, there has been a focus, I know for sure, on health education. The number of medical colleges have nearly doubled. We make double the number of, nearly double the number of postgraduates and undergraduate doctors. And also on a larger level, I think with the vision, the experience of Dr. Paul, he's tried to bring in changes which may take, it doesn't happen overnight. It's an ongoing process, but I think it's a humongous task. And there's no doubt that the private and the public have to work hand in hand. And during the pandemic, we showed that the silos can be broken, the trust deficit can be addressed if we actually work together with an open mind. So thank you very much. And now to Ritika, who's Vice President at IP Global, company that's in the development sector. She has implemented large-scale projects funded by international multilateral donors like USAID, BMGF, DFID, World Bank, etc., for improving family planning, maternal child health, and nutrition outcomes. So, Ritika, tell us about what you and your company organization have done, and how do you think it can be transformative, it can bring transformative change in the healthcare sector?
Thanks, Dr. Mahajan. So thanks to Ficci Heal especially for organizing this event, and Dr. Mahajan to bring and curating this panel and bringing diverse perspectives at the same table. And today I would also like to thank my parents back in Ranchi. They raised me as a brave girl, because right now that trait is very much required, especially to be talking after Mr. Shekhar Gupta. So I really need to be brave here. So what I would like to state some facts that in July 2015, when the Honorable Prime Minister launched Digital India, right? So that time the India's global per capita data consumption and the ranking was about 122 or 123. And after 8 years now, it's amazing to see that India ranks first in per capita data consumption. And in mobile per capita data consumption, we are using it even with US and China combined and put together. Like India's consumption is much, much larger than that. So why I'm quoting this data is because, digital transformation has of this stature in the last 8 years has actually, clearly set a pathway to, bringing and designing and implementing meaningful solutions. And one of that, and especially in healthcare, and one of that is telemedicine. And why telemedicine? Because it's gaining a lot of traction in the last, few years, and we all are aware about that. And mostly because now, again, data is with in the urban areas, in the rural areas, and the penetration is very high. And this actually leads to healthcare accessibility, as well as during the pandemic, like the 3 years that we all have, I'm sure everyone sitting in this room would have definitely consulted a doctor online, during these 3 years. And that is the wave that telemedicine has really brought in. And it has actually taken healthcare to remote and underserved areas, and bridging the medical, expertise to the, basically bridging the gap and bringing the medical expertise to the last mile. And with that, I would again like to quote this other data point that, again, all of us sitting here and the doctors sitting here and the entire, members, like we all know that 85% of our, healthcare needs can actually be catered by a general physician. But what do we really do? In the rural areas, we have quacks to whom people go to. And in urban areas, we have Google. And again, I'm sure, show of hands, how many of you really, in a certain ailment, like go to Google? Like if you all can show, I definitely go. Yeah, so as you can see, like many people reach to Google. But then now in the age of telemedicine, when we have general physicians who, if they are empowered with family history, individual history, lifestyle kind of data, like it can actually help them diagnose accurately, and it can actually reduce the cost of healthcare drastically, right? And in that entire movement, like IP Global, we are actually supporting, and I'll be talking about two of our initiatives, is actually partnered with Mera Doc, which is basically the first general physician, first mass market, low cost, relationship based, family physician concept. I'm sure most of you would know, as kids, at least we had a family physician to whom we would go for, all our ailments, and would know all our family history, and would actually treat in a very specialized way, and also refer to specialists as and when required, right? So Mera Doc is actually trying to do that, and is actually, brought together at least more than 350 plus vernacular doctors, 24/7, free consultations, again, virtually. And in the past, few months, we have been able to reach about 2.5 million customers who have been served through this. And I would especially like to talk about, and almost 10,000 doctor consultations per day. And over here, I would actually like to talk about something that Dr. Suri was mentioning, that, in a lot of her, hotels, she was mentioning that a lot of times, like, people are not getting, accessing, a doctor near Khajuraho would be so difficult. So I would also like to say that we have been able to bring first of its kind partnership with Make My Trip, where just with a cost of 50 rupees, like 49 rupees to be precise, you can get, for all the customer base who are booking flight options, who are booking hotel options through Make My Trip, you are able to get free doctor consultation during your trip. And also 1,000 rupees worth doorstep delivery of medicine, and 1,000 rupees worth of lab test if required. And that is the thing. And when we are sitting here in this panel, I would also like to say a new hashtag, because this generation of hashtags, that collaboration is the new innovation, and that is something that I think we all believe in, and I think this panel believes in a lot, because we will be able to sort of join hands and join forces to really bring that healthcare to the last mile, because again, using digital transformation, using telemedicine, and really bringing specialized doctors, general physicians to the last mile, so that, again, what Dr. Shekhar Gupta was also mentioning, that we should not, like, again, the access and affordable access would be available to the underserved and remote areas. The other bit that I wanted to definitely highlight also about, again in this space, because we're talking about private sector players, and we know that in India, again, there is a whole new wave of startups who are really coming together, whether it's health startups, they are medical devices, state of art. Again, government of India has launched and really wants to take this whole, self-reliance when it comes to medical devices industry. And today we are actually capable of doing all of that within the country. And over here, we have actually set up, world's first blended finance facility, which was, and this was set up during the pandemic. And again, thanks to Niti Aayog as well, that in February 2022, we are actually also launched this whole, white paper on blended finance. And basically, this was done and this whole blended finance basically brings together philanthropic donors. And again, going to be very sort of in simple layman terms, that a startup would require affordable capital, with a lot of times a bank or a bank would see them as a very risky venture. So that's why we are bringing and using philanthropic money in a way that we are able to de-risk some of that investment, so that we are able to provide affordable capital to the startup, so that they can actually take their solutions to tier 2, tier 3 and rural areas. So that is something that we have been doing, and basically mitigating the barriers for private investments and drive commercial investments. And in just span of 3 years, we are already seeing some light towards the change when it comes to like maybe banks earlier would require 100% risk guarantee in providing loans to the startup. Maybe now they have come to about 70%, and I'm sure such kind of efforts would also take this maybe to a much lower, and they would have a larger risk appetite when it comes to this. And because of this whole impact that we have been able to create, that we are able to work and support about 60 plus enterprises with just a funding of about $17 million. But with that $17 million, these 60 enterprises have been able to really scale up their solutions in a sustainable manner. They have been able to get loan, equity, they have been able to get multiple grants to the tune of almost 10x. And why I'm quoting these examples here is mainly because, again, everyone sitting in the room here, and especially the panelists, this new age financing is also sort of taking care of, the traditional grants. And we all know that the traditional grants are now ending. And most of us, used to have and worked on donor projects where 5 years a donor project would work, and then, the impact could not be seen after that because it was not sustainable. But now with such solutions like, blended finance, where we also have a tool like, recoverable grants. So a startup is given a funding for a short duration. Once their, work is done, they return back the money to us. And you won't believe that out of about 1 million that we have given to about 9 entities in the form of recoverable grants, we have actually been able to get almost 70% of that already. So that entire, the entire responsibility and accountability that the startups also take is very refreshing to see. And such form of grants is actually making us, use that same pool of money multiple times, creating multiple time, many-fold leverage and many-fold social impact. And all of this, we have been, able to reach about 43 million people in, again, and majority of it are in tier 2, tier 3 and rural areas. And for this, we have, also been able to been blessed with as the first Indian entity to get the P3 Impact Award. And again, these are just ways to say that when it comes to partnerships and when it comes to collaboration, I think that is the key to go forward. And if we have a single-minded focus of really reaching the underserved and remote areas, there are multiple ways to do that. So that is definitely I wanted to showcase here, and we can definitely connect separately.
Thank you, Ritika. This is blended finance is probably the way to go. I believe you've also funded some hospitals apart from startups. And what is this P3 award? I think it's a very prestigious award. Could you tell us something about that?
Yes, so P3 award, if just in a very layman term, if I can say, so P3 award, P3 Impact Award is given by the US Department of State and in partnership with Concordia and University of Virginia. So it's almost like an Oscar in the development sector world. So we were the first Indian entity to be getting that. And recently, again, the entire initiative has also been, we have also become the founding member in the Impact Investment Initiative, which was launched for global health, which was launched at the UN Security, the UN General Assembly. And I think all of this is actually just trying to showcase that in the last 3 years, like how we have created impact. And one example, Dr. Mahajan, I would like to give from the hospital. So how we have funded, so I'm sure most of you would know GNRC hospitals. It's the first tertiary hospital in the Northeast. So they wanted to take this entire their entire healthcare to the last mile, and wanted that more and more PMJ patients and more state insurance patients could come and know about the service and could come to GNRC to take healthcare within under these schemes. So when we funded them, so we funded them to basically kickstart their entire Swasth Mitra program, which was more like a door-to-door service to get screen patients and get them to the hospital. And while GNRC anyways provides very affordable healthcare, what we were able to do that in their revenue, the PMJ patients or the insurance patients was just 8%. And after the funding, in the span of 1.5 years, now it's reached to 30% of their revenue, which is coming from insurance patients and PMJ patients. And that actually sort of brings to the forefront, and also including the PMJ patients with, again, affordable healthcare, because that is what was the entire aim and target and mission of that entire, model and the policy. So, yeah,
Thank you for sharing that. And to Shekhar, I would say GNRC is led by someone from AIMS.
Yes.
A neurologist who left many years ago because he didn't get a job in AIMS, went back, set it up. So people from AIMS and other similar institutions, even when they come out, they do good work. It's not only that they do good work when they are there.
No, that wasn't my point. Was that there should be a lot more, so this talent goes out and it's available, like the IITs. Now IITians are doing all kinds of things, and IITs, the growth started much earlier. More IITs, good quality public medical education. Public medical education is still, and public engineering education, public management education still is way better than anything available in the private sector.
I think we've had great discussion, and now I leave it to Dr. Paul to sum it up. He's made copious notes, and I really sincerely hope that the discussion of today would lead to some impact. Ultimately, everything is about impact, and Dr. Paul being amongst us, being able to hear divergent voices. Let's hear him now. In conclusion, he has a flight to take, and that's why I think we'll end on time.
Well, thank you very much. The discussion has been stimulating, and coming to forum like yours is a unique opportunity because you hear 360-degree perspectives from successful people, thought leaders of all walks of life that matter in a very big way to our nation. So thank you so much for the opportunity. Let me pick up threads from the second half of our discussion on supply issue, of access issue, affordability issue of healthcare. Let's begin there. It is indeed a fact that we started with as a nation, as a free nation, with a handicap of being practically no public health infrastructure and a little private sector. At that time, the life expectancy at birth was 27 years, 1946 data Bohr committee. Today we are close to 70 years. The nations with whom we compete often are in the range of 82, 83, and some at 85. Just to tell you the journey that this nation has moved. Health is an outcome of many interventions that are not necessarily only related to the health sector. So that's just in the larger perspective. In recent times, in terms of supplies, the point needs to be made that very sincere and impressive efforts have been made. And in that regard, since you mentioned about the medical education supply, let me start there. We'll move to the future dialogue, but just to get the things in the right perspective, under the leadership of the Prime Minister, we had 387 medical colleges in 2014. Today we have 716. There was a dominance of the private medical colleges. It happened in a spate of, few years in a certain way at some time in our history. Today, that ratio is technically reversed. We have more government medical colleges, and those whose children have been competing for NEET, they all aspire to be, by the way, sir, in public medical colleges and not private medical colleges. So that also is an important point, and we strive very hard to maintain high standards. Doubling of the seats, UG seats, must be stated in this forum. Of 52,000 MBBS seats, today we are 108,000 seats. In PG, from the NMC system, all let's said together, about 32,000 seats we are 68,000 seats and rising. The short point is that the HR supply is being addressed in a very big way. We have crossed that very modest WHO benchmark of 1 doctor per 1,000 for the allopaths. And if we add Ayush doctors, then we are already something like 1.3. We have a long way to go, surely, because the nations with whom we compare ourselves have typically about 3 doctors per 1,000, and definitely 2 per 1,000 is the need, coupled with the right distribution, and before that, the right mix. And on the right mix, the challenge for our nation in a big way is to make special efforts to raise the specialists number, the pipeline stronger. Typically, for most specialties, we have one specialist where we should have 4 or 5, so 20%. For general, as I said, 1 per 1,000 is met. We can go to 2. That's 1:2. But for specialists, it's 4 to 1. Okay, 1/4. So concerted effort to move in the direction of specialized workforce. And you know my take, and let me done with that the private sector hospitals hold a treasure of training postgraduates through the National Board of Examination system. And please come forward, and I'll request you to do a story on that, because they don't do that optimally, sir. Moving to other parts. Infrastructure. Efforts have been made. We're talking about 22 aims. Tertiary care. There is an expansion at the medical colleges level, which I've already referred, which let's call it secondary or secondary plus. In medical colleges, district hospitals, critical care units, mother and child blocks, super specialty blocks, and in PMA BHIM, other quality, other aspects of infrastructure are being addressed. Just to let you know how the train is moving in terms of efforts that are being made. But I want to also, perhaps by way of introduction, may also say that out-of-pocket expenditure compared to, say a few years ago, 63% is now down to 47%. So somewhere down the line, the access and affordability is also happening. Much more of this should happen. That's our endeavor. We should be below 24, below 20 out-of-pocket expenditure, and someday even lower than that. So this is just to put on record the efforts that are being made. But now I'd like to be a little more specific. The major infrastructure push, I touched secondary and tertiary very quickly, is in the space of primary health care. And we need help from all of you. From, between 2018 and today, our sub-centers and PSCs of the olden times have been transformed into a next level of infrastructure and capabilities and HR by way of creating Aayushman Bharat Health and Wellness Centers. 161,000 sub-centers plus PHCs put together have been taken to a next level of care as the bedrock of our primary healthcare system. How are they different? Well, firstly, the old sub-center and the old PHC was largely mother and child, family planning. That's historically, that's how it was. And a platform for communicable diseases. And some effort was being made, started in our previous decade, on non-communicable disease. But then the Health and Wellness Center mission is very clear. We are moving in the direction of comprehensive primary health care, spanning not just maternal child health care, communicable diseases, focused non-communicable disease, specifically hypertension, diabetes, and also liver and kidney in terms of screening and treatment pathways for cancer. But moving on to mental health, geriatric health, palliation, ENT, eye, it's all in the design. What has been achieved so far is the creation of a platform. And that deadline, doing so by December 22, has been met. Between 2018 April and December, this commitment of 150,000, we have exceeded that now, has been achieved. What you have there is in a sub-center, new mid-level provider called community health officer, who is typically a trained BSc qualified nurse with additional training and orientation. In some states, the Ayush doctors are playing that role, and there are some other minor variations, but typically from the best wisdom available at the time, that the sub-center health wellness centers can be managed with a mid-level provider, not the A&M, not yet the medical officer. Someday we will have family medicine GPs that you talked about. Someday, I'll come to that toward the end. But today, new worker, 150,000 plus new professionals have been put in place in this short period of time. My request to you now is to please join hands to get the packages such as the mental health and geriatric, for which we are moving in any case. They need to be placed on top of the platform that has been created. If we don't quickly and seriously do that effort, and it's our job, all of our job, then this platform will not fully realize the potential for which this effort and public money has been spent. So the good news here is that we have a platform in terms of the infrastructure increase done, telemedicine in all these facilities done, CHO put in position, and at PSC, doctors put in position, because that health and wellness center is under the leadership of a medical officer. Please help us now. We are doing our own effort, but please see how you can help to translate that the total vision of 12 packages, comprehensive primary health care from limited primary health care, to be layered on this platform, which is already gone to the tune of NCD and some other stuff, but we need to take it to the fuller manifestation. Primary healthcare typically is the business of the state, not that there are no private providers, and we welcome them. Let there be, plethora of trained doctors. What we don't like is those doctors that were referred, untrained लोग, वो तो चाहिए ही नहीं, उन्हीं को तो पीछे हटाना है. हमें ट्रेन लोग चाहिए. एक प्लेटफॉर्म ये बन रहा है. उसके अलावा प्राइवेट प्रैक्टिस करें, जो भी लीगली अलाउड प्राइवेट प्रैक्टिस है होने चाहिए. गांव में भी आए, कस्बों में भी आए, उसमें कोई इशू नहीं है. स्पेशलिस्ट भी आए. बट टू मेक दिस फंक्शनल and to be seen through the eye of public health, which means these are the sites for ambulatory care, outpatient consultation, health checkups, treatment, continuous treatment. And I assure you that these CHOs make sure in places, not everywhere perhaps, to ensure that the hypertension medicine that has been prescribed to one of their beneficiaries, that 6,000 beneficiary, if exhausts, they also go and deliver it at home. वो भी हो रहा है. ऐसा नहीं है कि पूरा sincerity से कहीं काम नहीं हो रहा है. How do we get the best out of this great platform going forward is the challenge. But we have moved up to this level. We now need to go to the next higher level. We are committed there to have as many as 105 medicines and 14 diagnostics at the sub-center health and wellness center, the CHO-led health and wellness center, and 170 medicines and 63 diagnostics in some way or the other for the medical officer-led PSC health and wellness. So the aspiration is clear, and we'll work in that direction. The first job of having the infra and people, critical personnel in place, has been achieved. I'd now like to mention the second part, and that is after Aayushman Bharat PMJ, which happened together with Aayushman Bharat Health and Wellness Center, the two pillars, there is only one sector that in India, one health sector. Public-private health sector is now one sector because the bridge is the PMJ. Through the PMJ system, the beneficiaries, we can come to those numbers, 40% we started with, the bottom 2 quintiles, but actually as of now, half of Indian citizens are covered when you add the schemes that the states have layered on the PMJ platform. So technically, the secondary plus and secondary and tertiary care hospitalization coverage is technically taken care of under the scheme today. This should move to higher quintiles, and that's a challenge where discussions on another day will be very useful, where insurance and other issues will come. But the short point is, in an unprecedented way, in half of India's population, elderly, children, female, male, adolescent, essentially covered through 1,500 plus packages by the government including union, in partnership with the state governments, because this is a centrally sponsored scheme. So Aayushman Bharat provide, and that's a change. That wasn't there a few years ago. And through that, the more importantly, and we want to build on that, there's only one sector. The artificial line of where public and private happens is gone, because this mechanism provides care to the beneficiary in the private sector as well as in the public sector. Incidentally, what the public sector earns, let's say AIIMS earns or Safdarjung earns, is flowed back locally into that institution goes back to the government hospital for further usage in terms of medicine supply or even incentivizing the doctors. So the short point that I'm making is this is a change and a significant change. Again, time has now come to see how we go from here further up. How do we cover the individuals who are today not fully covered? And Niti has used the term the missing middle. How do we address that? And we could then discuss the ways and means of doing it, how much of that should be publicly funded, how much should come from the insurance side. Unfortunately, an exciting insurance product or products which can cater to equivalent coverage, even the equivalent coverage of 5 lakh per family per annum is not there, and that's where we need your help. We have been talking about it, but this has not happened. For this kind of a coverage, the insurance product today is something like 24,000 to 48,000 to 53,000 if an elderly person is also part of your family. This needs to be addressed because this is so important in this paradigm. Having said that, let me wrap up by adding to this the fact that in public health, there are also indirect investments which should be noted. Every second, a new water connection is being delivered in India. When the Jal Jeevan Mission started, only 16% households had water supply, potable rural households. Today, this has risen to 65% and more. At the end of this mission, 70 crore individuals would have got potable water supply, which means safe water supply, which means health improvements. I'm not adding the sanitation, the such mission. If you add that, then in terms of overall public health, there are huge achievements that need to be addressed, and add to that the air pollution, indoor air pollution being less through Ujjwala Yojana and so on. So the train is moving, it should gather more speed. We need your participation. And here, we have a bed strength of 1 per 1,000. It should, under the policy, should become 2,000 by next year, 2 years from now. How do we move in that direction? So let's come to increased supply of infrastructure from the private sector side. Currently, we are about 7 lakh beds, I think, in the private sector, around about that. A total of about 13 lakh beds. If we want to be 2, which means 30 lakh beds. Please, how can we create 1 million or 1.5 million beds in the private sector in the next 5 years? Can we debate that? How can we help? I heard a suggestion about, status of industry. So let's build on this. Let's sit down and look at what is it needed, what is the other side of the story, and how we can work together. How can we move to tier 2 and tier 3? What is your take on some of the schemes such as the VGF scheme, which were offered in partnership, hearing from you, but have not really been taken up in a big way? How can blended finance can be done? I used to hear idea about priority lending, etc. from RBI in the social sector infrastructure. It used to be modest 5 crore. Now it is somewhat less modest, 10 crore. But we moved in that direction. But nothing happened. Why the progress of faster creation of health infrastructure is not happening? And conversely, what is it that we can do together to take care of it? I believe there is a potential in the cooperation sector coming forward. We would like to examine how it is to be done, and to be specific here, on the 18th of November, NITI is holding a day-long consultation. You will be informed, and we will look forward to the ideas on this. When I talk to the tier 2 health providers, nursing homes in particular, they say compliance is a very big issue. हम सब investment ले आएंगे, हम ये भी कर लेंगे, वो भी हमारी compliances कम कर दीजिए. So one of the themes that we have picked up is to try to study the need for compliances in these places so that relatively modest players can come in more easily. So ease of creating health infrastructure in these places. We look forward to several other ideas on this, and in particular how a public-private partnership can emerge. Land has been flagged Thank you very much. We will see. When I talk to state governments, when we go on these state missions, everybody is willing to give land. The chief ministers are willing to give land. आप आके बनाइए, हम दे रहे हैं, बिजली भी देंगे. इसको कैसे स्ट्रक्चर करें, ये करना ही है. इसके अलावा चॉइस कैसे हो? अगर हमने हेल्थ इंफ्रास्ट्रक्चर 1 per 1000 बेड की मॉडेस्ट कैलकुलेशन से हमें 2 बनाना या 3 बनाना है गोइंग फॉरवर्ड, तो प्राइवेट सेक्टर की इन्वेस्टमेंट ही क्रूशियल है इन अ वेरी बिग वे. पब्लिक सेक्टर विल गो ऑन जैसे हम चले हुए हैं. बट देन एज आई सेड, we are looking forward to a bigger partnership in the tertiary care, secondary plus and tertiary, primary primarily by the government, and that's the focus. National policy talks about 2/3 of the resources of the government to go to primary care. We are doing exactly things in that direction. We are at about 55% because we are busy also to create, AMSAs and others. And we need that presence for us to be able to be in the leadership. We need science, we need technology, we need specialties, cutting edge, systems and PhD programs and so on in the public sector universities, which is what the AMSs are and other institutions. So our investment will have to go in that direction, and also pace setters for quality and for affordable care. So we need all that. But the commitment to primary health care is strong, and I look forward to opportunities how to go in that direction. Second point, and there will be only 2 more points on school points that you raised, sir. It's a unique point that came up in an unexpected way, but very happy to inform you that this is an area which has the attention of the government. We actively have produced a blueprint on school health program for the nation, comprehensive school health program. The direction came through discussions and to look at programs such as the RBSK program, RKSK programs, and bring them all together for the care of older children and adolescents. The short point that I'm making is that a vision for school health, national Aayushman Bharat school health program is being thought about. And we have considered 6 pillars, just to tell you that we are moving systematically. Awareness and health education to the student, screening of illnesses, including learning issues and how to respond better than what we are doing now. Mental health in a very big way, huge big way. This is a missing part, but everywhere perhaps, but particularly in private, public hospitals. We have the telemanas trying to do help, but we need more for both teachers and students in particular, in partnership with the parents. Then health promoting environment of a school, which is about nutrition and which is about how health is visible on a daily basis to the pupils, and physical education. And last but not the least, acute care and provisions such as iron, folic acid, sanitary pads, and tomorrow maybe HPV vaccine. So the contours of the school health program have been visualized. We're happy to receive your comments and your ideas. If an opportunity to learn more be created, we would be very happy to do so. Just a reminder on that, and that everybody should know that indeed huge problems in our adolescent age group. I believe 1/4 of them have stress of a certain kind. Everybody has stress from time to time, but at a given time about 1/4 of our children are stressed. You'll be surprised, 10% of our adolescents are pre-diabetic. 10%. Yes, this is our CNNS survey done, very high quality work on HbA1c and fasting blood sugar. 10%. 5% are hypertensive already, and anemic. 57% adolescent girls and 31% adolescent boys. If I am anemic, I can't do geometry. I can't understand the full article that Shekharji would produce. नहीं कर सकते concentrate. So इसको address करना है. This is happening right now, and I would again invite your partnership in that regard. One last word on the issue of general practice, and I need help on this. Yes, once upon a time there used to be a general practice, a medical doctor of the family. that went away somehow. I don't want to go into the reasons, but one reason which should be known is that in today's time, in 5.5 years of MBBS, to compress everything from newborn to geriatric is not really easy. Men, women, adolescents, not really easy. It just doesn't happen. UK's GP takes 6.5 years of MBBS equivalent and then 5 years to become a GP. You need extra competencies. And one reason is that acute care, one decision on that day, I can teach the student. But how do I follow up a patient with diabetes to know when to change? Now that doesn't happen the way the curriculum can be designed, because you move from one posting of 6 weeks to another department and then another department. You come back after a year to do a repeat posting in that department. So the continuity of care is fundamentally missed. And GP is all about continuity of care of that individual, that family. Therefore, what you need is family medicine as a specialty, as MD family medicine. The course exists, but you'll be surprised that there are only 3 institutions out of the 716 or 387, which are more mature, who are doing the family medicine course. There's no traction. But when I talk to people like yourself, you say, तो private में भी scope है. लेकिन कोई डिमांड ही नहीं आता. प्राइवेट के इतने मेडिकल कॉलेजेस वो शुरू ही नहीं करते इसको हमें हेल्प करना हो. Is it that we have already gone the American way at super specialization, fragmented care? Where is the holistic care? So we need help on this, but a decision to start MD family medicine courses in the AIMS system, which is directly GOI system, has been taken, but then that's only as a benchmark. Family medicine MD should happen in many, many places. And it should be seen as a specialty. It will also be seen as every MBBS and can go for a PhD course or MD, MS, but also into MD family medicine. We need to create debate around it, but would you please tell whether there is a demand for such individuals in hospital that you run? क्या वहाँ पे होगा कि नहीं होगा? फिर क्यों इसकी बात कर रहे हैं हम लोग? इसका क्या इलाज होगा? हमें we have to find a middle path on this. So someday we will discuss this more. I think the society needs such doctors, but a narrative has happened now for some reason over a period of time. It's all fragmented. जब जरूरत पड़ती है तो ढूंढते हैं पेयर फादर को कौन देख पाए, उसकी छोटी सी स्किन प्रॉब्लम को कौन देख पाए, मेंटल हेल्थ के लिए फिर साइकाइट्रिस्ट ढूंढो, साइकाइट्रिस्ट है ही नहीं. इसके लिए मैं चाहता हूँ कि इसके ऊपर चर्चा हो और क्या ये क्रिएट की जा सकती है एज अ हायर कॉज, नॉट नेसेसरली कमर्शियल. इफ इट इज नॉट कैन नॉट बी डन, need not be done in the current paradigm of hospital. Can we find another way of doing it for the society? और कोई तरीका हो सकता है क्या? इसके बारे में मैं चाहूँगा कि चर्चा हो. So in short, efforts, very sincere efforts are ongoing. Please help. I've heard a lot taken, notes as we used to do in AIMS and more. And I'll take it forward. And indeed, the specific things that I mentioned is a discussion on the 18th, which please, we will be involving you if you're not already been involved. It's being lined up. And school health ideas are welcome. Blended finance, other ideas are welcome. And we'll work together for ease of creating healthcare infrastructure in the private space. Thank you very much.
Thank you. Thank you so much, sir, for summing up so beautifully. I know you have a flight to catch. Those messages have been coming. I take this opportunity to thank my panelists, Dr. Dharmender Nagar, Dr. V.K. Shunglu, Mrs. Jyotsna, Dr. Jyotsna Suri, Mr. Shekhar Gupta, and Ritika for this wonderful discussion. And we will measure at some point of time the outcomes of what we discussed here. Thank you all very much. And to the audience, thank you. Thank you so much.
Thank you very much, sir. And special thanks to Dr. V.K. Paul, sir. It is indeed a pleasure to have you over here. We take a break over here for lunch, which is being arranged on the 3rd floor. And then we assemble over here for the next session, which is on empowering her health, especially for the women in health. Thank you. Want to kindly take up the seats, please. We shall begin this wonderful session, which is on her. Yes, you heard it right. It is specially for the women, by the women, and obviously it will benefit every woman in the society too. For this particular session, we have the guest of honor, Mrs. Roli Singh, Additional Secretary and DG, CGHS, Ministry of Health and Family Welfare, Government of India. Can we have a big round of applause for ma'am, please? Thank you. We have special guests, Ms. Ritu Mahajan, Co-founder and Executive Director, Mahajan Imaging and Labs, Ms. Upasana Arora, Co-Chair, Ficci MVT Committee and Managing Director, Yashoda Super Speciality Hospitals, Ms. Vinita Sethi, Chief Corporate Affairs Officer, Apollo Hospitals Group, Dr. Taneja Nisari, Director, All India Institute of Ayurveda, Ms. Amrita Sekhar, Senior Program Officer, Innovative Health Tools, Bill and Melinda Gates Foundation, and Dr. Sunila Garg, Chair, Program Advisory Committee, NIHFW, Professor of Excellence. As a moderator for this session, we will have Ms. Susan Ferguson, Country Representative India, UN Women. And the virtually joining guest is Dr. Bharti Praveen Pawar, Honorable Minister of State for Health and Family Welfare, Government of India. She will join anytime, but I request all of you to kindly extend a very warm welcome and a big round of applause for all the wonderful ladies on the stage. Thank you very much. And I now humbly request Ms. Ritu Mahajan to kindly hand over a green certificate to Ms. Roli Singh. Thank you. With this, we kickstart this wonderful session, and I humbly request Mrs. Roli Singh to kindly give her remarks on this occasion.
I thought there would be some context setting before that, if that could be possible, because I mean, I have a lot to say.
Sure.
But
we truly agree with that. So can we start with Ma'am Ritu? Yeah, okay.
Very good afternoon to this esteemed audience. Totally honored and humbled at being invited for this session. Ma'am Roli Singh and the other various dignitaries whom I have this wonderful opportunity of sharing the dais with this afternoon. Thank you very much, Ficci. At the onset, I would like to say that this being the decade of women is absolutely the most wonderful thing Ficci could have thought of today. Healthcare for women. As I stand here representing my company, founded over 32 years ago, we actually never thought that I would be empowering so many women in our company today. We are very proud just to let you know that it's not just talk, but it's a fact that in the whole span of over 800 staff that we have, 36%, if not more, are women from all diverse stratas of society working for us. Thank you. And to top it all, let me also share that 50% of the senior management team are women. And
we are not surprised.
Thanks, Arvind. And also, to top that up, the doctors that we have, 50% of them are also women. So I think it really has brought us a long way today. And the little that we are able to contribute as a family of Mahajan has made us very proud today, you know. that we are able to do our little bit in the society. So at the onset, I would like to say that definitely women have been totally so important in the society, and absolutely true that being a woman myself, I can surely say that most of the women today have always neglected their needs of health, be it mental or physiological. And it's not that, you know, you've got anything to do with the affordability, frankly. Even friends of mine who belong to the higher status of society, so often we discuss it. नहीं यार, हो जाएगा मैम, हो यार, कोई नहीं, करा लेंगे, क्या फायदा? You know, things like that. And it comes from people like you and me. So it just goes to show that their own health is least in the priority. They will definitely come with their husbands, health checks. मेरे husband का health check होना है, या cardiac होना है, ये होना. But when it comes to their own, who is going to bother about that? Who is going to look into that? You know, it's a very, very big problem. And Ma'am Roli, I really hope, being a woman yourself, you know, you are able to take this up as a very, 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 very strong matter for all of us. You know, I'm sure you face it all the time at home as well. How many times have you gone and got yourself tested? You know, as a preventive reason. नहीं होता है. 36% of the TB cases in India, again women. Okay. It's really, I mean, strange. The number of preventable diseases women are facing, things like childbirth, pregnancy, respiratory disorders, you know, which could be looked into. A lot of them are women. Globally, jitne bhi, if my thing is right, I was told that about 800 women globally die every day due to these preventable causes. And out of that, 20% are from India. So that really speaks volumes, you know, for the country, the state that we are in, ma'am, today. And this is, I mean, what can we do as healthcare providers, as the diagnostic chain? We are really trying to encourage women from all kinds of society to come and join. And it's a fact that today when they come and approach us, we actually look at them, ki she can be trained. Doesn't matter, even if she's only 10th pass. And you'll be surprised, you know, that even a 10th pass girl in our company is the one who will be filling in your name and details on that computer in the ultrasound room. And they are so empowered at home. Isn't that important? They are going to be bringing forward to you better generations, healthier generations, you know. When they go home, they feel so much more privileged that today I have taken my salary home. They don't want to sit back at home anymore. I have families and families who've brought forward their women to join us, you know, and we have never said no to them. They have come from very small villages. And today you'll be surprised when you meet them at work, you know. They would look just like any one of us. So I think that the healthcare industry really needs to come forward and bring these women out into the open now. Once you educate them, nothing will stop them from being looked after. They are the healthcare providers today. They understand the needs of the women today. They are going to be able to take things forward for us. We are trying to instill these values in them so that they're able to, from tomorrow, bring forward a new generation whom they're going to produce. They make sure that education becomes an integral part. So when we are diagnosing, we have realized over the last few years that so many more women have come up in our ultrasound cases. The number of females, be it rich or from poor backgrounds, the numbers have increased. We have about 4 to 5 turnarounds, for every pregnant woman for the various monthly scans. That's really increasing. The numbers are going up. Mammography, it's increasing. We see our own data in the company. And I think even today we are, in our research department, we are happy to say that we have 4 to 5 major research projects being taken up on mammography. So it's part of this diagnostic healthcare industry that if we are able to do anything like this, I think we are going to take the country forward with a lot more gusto, which is what we really need. I think if each one of us today as women go back home and bring this message and start looking after the other women as well and give them this knowledge, it's going to be a big deal and it's really going to make a change in whatever which way we can. I think I've said enough. Thank you so much.
I would just like to understand the format. Am I chairing the session? Because I was supposed to be one of the speakers and then...
Yes, so we wanted you to open the floor, but it's okay if you want the other women to first participate, talk about it, and then towards the end you want to speak, or along with it you can do it.
Because this is a surprise. This was not part of the format. I was just supposed to be one of the speakers. The minister was supposed to come.
She was to join virtually, but she's not able to join for some reason.
Panel discussion, right?
No, the open consultation is going to be there.
Okay.
Yeah.
You're going to...
Yes, Miss Suzanne is going to take over.
After we all have spoken?
Yes, please.
Okay. Yeah. Okay.
Yeah.
Right. Okay. Okay.
Yes.
Was a little...
So now I thank Ms. Ritu Mahajan for your concerns regarding the women health, and thank you for the suggestions. We shall make it a better place for other women too. And now I invite Ms. Vinita Sethi, Chief Corporate Affairs Officer, Apollo Hospitals Group, to share her remarks and also to talk about in brief regarding the Ficci initiative. Thank you.
Good afternoon, and it's just wonderful to be in this group, and I'm so happy to see men having joined this very important session of Empower Women's Health. And I think it's a responsibility of multiple stakeholders. So let me come to how this initiative really developed. You see, a lot has been happening across the country. Ritu has given some fabulous statistics, and a lot of us as providers have been collecting this kind of data. Sangeeta Reddy, who's the former president of Ficci and was a part of Empower, actually G20 led this wonderful project of bringing women's welfare empowerment on a G20 platform, which, as you know, India is just inching closer to wrapping up. And we had a wonderful communique. In fact, just now I'm coming back from a very good a meeting on women in G20. So what Sangeeta felt, that when you talk of women's empowerment across, it comes out in various forms, in livelihoods, empowering them with education. But I think the critical thing in all this is what you call a fair access to resources, where health has emerged as one of the top resource. So in India, when you look at the stats which Ritu has spoken of, in fact, in Apollo, we've done a study, and I won't bore you with the stats again, but just to tell you, the incidence of NCDs in women in the data that I got from Apollo hospitals, which Sangeeta shared with me, is that NCDs in women is just going unnoticed. 20% of women screened are diabetic, 23% are pre-diabetic. And mind you, pre-diabetic is something to be taken seriously. We have a galaxy of doctors here who can talk to you about this. 8% have hypertension, and as Ritu again said, we deprioritize our health. We are the caregivers, and we are the last ones who take ourselves for screening. And I think a lot of disease management can happen wonderfully if we nip the disease in its bud. And the other thing is, it's not just NCDs, the nutritional disorders. You see the anemia statistics, you'll see where women are, bottom of the rung. Early onset of breast cancer. It used to be earlier above 60 or whatever, 55, that we used to go for screening. Today, girls as young as in their 30s are being diagnosed for breast cancer. And in general, holistic women's healthcare, because as you know, shadow pandemic in COVID has increased something we all face, something that we actually didn't acknowledge, the mental health issues. So when all this was discussed, even in G20, it was common to all the countries, the shadow pandemic, the rise of NCDs amongst women. And that's when, we as Apollo Hospitals proposed that we must do something more towards pro-health, towards building an attitude amongst women to go for preventive healthcare. So then I think Sangeeta had a discussion also with the Ficci team, and we all sat together and said, let's make a sustainable project in women's health. So today's meeting is just a launch, and we propose to do this health meeting across different cities in India, where we are going to look up, along with the multiple stakeholders, different aspects of addressing a woman's health, starting with creating awareness, to working with the governments, including center and the state governments, to get a gender lens on the budget allocations. 3, working with bodies like UN Women to have a peer exchange, share best practices, and create more awareness jointly, and also see where we can tie up with your projects. Work with multiple private sector, stakeholders, diagnostics, secondary, tertiary, quaternary, at the same time also companies in medtech, who, for example, we in Apollo have a preventive healthcare tool where we've developed an artificial intelligence cardiac score. So we see a predisposition of people to cardiac arrest. Women's bodies, our anatomies, make us different from men. And if you see the research, there is this accusation that often, and correct me if I'm wrong, that often a lot of research is on men, and women often are not really enough, taken into research. And I today went through a Microsoft data where even Microsoft is looking at it, that how is it that we can make the data more inclusive to include more women subjects in it. So, we have a whole menu of stakeholders we can work with. And this is the agenda of what we are doing today, this session today, to bring all stakeholders together. So with this, Susan, we can take forward the discussion.
Thank you very much, Vinita. So I have the sort of enviable job of being able to bring forth all of you to talk about some of your areas of expertise that connect with what you've just been saying. So from my point of view, I just wanted to sort of set the context a little bit further. And that is that, of course, meeting women's health needs and eliminating, the gender gaps between men and women are crucial to create resilient societies. There's been, I think when people think of women's health, they often think of sexual and reproductive health, which is, of course, crucial. And there have been many advances in this area of health over the years. And that has really returned results also for countries as a whole, women themselves, children, and also countries. For example, between 2000 and 2020, Nepal reduced maternal mortality by 65.5%, and in India it dropped by almost 70%. So these are incredible gains, and they're also part of meeting the Sustainable Development Goals. But now, as our previous speakers has mentioned, it's really time to look beyond maternal health into other issues that women face, other health issues. And, you know, I mean, women do live longer than men generally, but we also have specific health needs and higher morbidity in certain areas. And, you know, of course, we have to have a life cycle view of women's health. Many women are no longer in the childbearing ages, yet we still experience different health issues related to our bodies, but also related to the roles that we play in society. It's not just about biology, it's also the kinds of roles women do. And as an example of this, last night I burnt my hand getting a pot out of the oven. I was dealing with some childcare issues. My 15-year-old daughter was having like an anxiety attack, and I was not thinking about cooking, and I reached around, I picked up the pot and burnt my hand. So it was such a good example of gender norms. You know, it was me in the kitchen dealing with the food, dealing with a children's issues. And these things writ large affect women and men differently because of the roles that we play in society. And as Vinita has just said, you know, there are chronic conditions such as arthritis, osteoporosis, and also depression, which impact the quality of life of women and are experienced at a higher rate in older women as compared to older men. Also, as you have so clearly put it, that women in the health system are a force for change. You know, they're both a force for service delivery, but also women in leadership positions, such as we have demonstrated here today, are really a force for improving the quality of life of women, men, girls, and boys. Women also, because of their gender norms, often play a role at household level in nutrition, provision of nutrition for the whole family, we know that when women earn a living themselves and have control over that income, they're actually more likely to make household changes in water and sanitation provision, or just in having healthy houses that lead to better health outcomes for everyone. So women have this transformative change in health for everyone. They have a role in health care, and they also experience health issues differently. And this is what we're here today, to really unpack some of those things and see what is already working very well. And India has many great examples. And then to take it further, what can we all do about this? So I'm going to first turn to Upsana, who would be able to give us some background from your point of view.
Thank you, Susan, and good afternoon, everybody. Basically, when we talk about women's health, then I am happy that at least few empowered females are here and we are talking about women's health. But it's generally, if you see, it's not on ground. Only few females are empowered and they are talking about health. Like, I look after my health, well, all of you are looking after your health. But if you see, 24% of women are malnutritioned, they are having anemia, and they are not even aware about it, that they are having this problem. Reason behind it, our social, if you see background, females are always second priority in a family. So if we talk about women health, we are supposed to change our family values, where we are not giving enough respect to females, not they have rights. And I believe women health started from the time of pregnancy. Either it's the mother who is having a child or child who's inside the mother. Because whatever is happening with the mother, everything is impacting on the child. Even in this era, when we are actually, females are doing all wonders and they are reaching to, top, is still at home, rural area, if you go there, at the time of dinner or lunch, they are not getting nutritional food. Still there is a mindset what they will. लड़की है, इसको क्या ज़रूरत है मक्खन खाने की. So this mindset has to be changed. That is why lots of maternal deaths are happening in the, especially I'm talking about India. And Susan can explain more about world, that what is happening in the world. There are many things behind this reason, because we are trained, our mind is trained to take ourselves at the last in the queue when we talk about family. We are used to feed everybody, we are used to look after everyone, but we think जो बचेगा अरे देखते हैं पहले बड़े लोग खा लें, पहले बच्चे खा लें. So this needs to be changed now. When we talk about healthcare, everybody is thinking about that my child is not growing well or my husband is looking sick. Such kind of tension we are always having in our mind, but now we are thinking like this, but others, I am talking about those who are not empowered, who are not very much aware what is happening in the world or in the society. They are still thinking that they are everyone is important, just they are the one who is not important. So first of all, we are supposed to tell all females, and as Ritu said, that we are supposed to take this message away from this place, and we are supposed to, and I am used to tell everyone, we need to make a chain. Every woman who are sitting here, they are supposed to adopt at least 10 more women who are not educated, who are not empowered, to create awareness and to create not only physical health. If you see, there is lots of things happening in mental health also, especially females, because of sometimes it's domestic violence, sometimes suppression of their emotions. You know, we are not able to express our feelings, because if girl is laughing loudly, mother is telling, ladki ho, itni zor se mat haso. If she wants to, express her anger, everybody will say, dusre ke ghar jaogi, ye sab mat karo. So this is not India, where we are sitting, Ficci. This is not India. It is not Bharat. We are the one who are actually organizing seminars, talking about this, writing lots of articles. We need to go to reach those who are not aware about anything what we are talking here. Ms. Roli Singh can tell actually in length that what is happening exactly on ground. So I want that if somebody wants to create a healthy society, female needs to be physically and mentally very healthy. Only then that family will be healthy, mentally and physically both. And education is must to make a healthy country. And if female is educated, then she can make her family educated. Not only family, like I don't know how many of you are, giving fee to your drivers' kids or your helpers. So we are doing such kind of things, and it is high time to create this awareness about among all those who are not aware all these things, and they are not aware about what is the value of education as well as health. So like safe drinking water and Swachh Bharat Abhiyan, this is very important, but important in only few areas. Like if we talk about Delhi, Lutyens Delhi is beautiful, but if you go, bastis and all, you will find they are not aware about menstrual hygiene. We are providing, lots of NGOs are providing, even I have adopted 100 girls and I am providing them health and, whisper and everything. But to dispose of those things, use of awareness about hygiene, they are not aware. So it's really lots of work needs to do. Among those who are not privileged, like us, who are sitting here and talking big things that we can do this, we need to educate them, and it is not a big deal. If they are 10th pass, like Ritu was telling, and they can do so many things, and even I see like my hospital is full of women, because nurses are generally females, as well as I am a leader, so I have to, encourage female staff. But same time, those people who are working, they are aware, because if my 4th class staff who is working in the hospital, they are very much aware about hand hygiene and all. But we are supposed to go to those areas where they are not even looking after their bath. If you are providing them shampoo, still they will not use that. So it's a time to take an oath, all of us, that we are going to take this initiative further, that all women has to be healthy. Thank you so much. I think there is some... So thanks, and thank you, Ficci, for organizing this wonderful session, and especially when Susan is here, she can tell us about what is happening in the world, and Roli Singh, who can make policies and implement that also. So Roli ji, I think whatever we are telling, you are going to, utilize our thoughts and going to make a change in women's life who are actually suffering. I should say this word suffering, because they are not able to express their desires also. I have done a puzzle in a kitty party. All females, they are belonging to good families. I just asked them a question. What was your dream before your marriage? Just give me answer. There was, I think, 25 females were there. And what do you want to do? Everybody was having, only 3 females were having some dream in their life, that they wanted to become this or that or something. Everybody was happy. Acha ghar, my kids are happy, I am happy. My husband is happy, I am happy. So they think that they are not individual. They don't have any individual personality. They are always happy whatever is happening in the family with husband and kids. So I just want to change this. I am happy Mr. Arora is not here. Otherwise...
Thank you very much, Prasanna.
So thank you so much, and Ficci should organize such kind of conferences more often. Thanks.
Thank you. So next we'll turn to Ms. Amrita Sekar for her comments as well.
Thank you, everyone, and good afternoon, Madam Roli Singh and the dignitaries on the stage, and thank you, Ficci, for organizing a very important consultation. The advantage of speaking after so many eminent people is a lot of what needs to be said has been said. I'll just quote a few facts and figures in support of some of the data that has been shared. I'll focus, at least initially, on the fact that women's health R&D, women's health innovations are grossly underfunded. To give you an example, we alluded to the fact that women suffer cardiovascular disease differently from men, and it's the global cause for mortality in women, one of the leading causes. However, in clinical trials which have evaluated treatments for cardiovascular diseases, women are not included and are very underrepresented. So there was a drug called digoxin which actually got approved years ago for heart failure treatment. And it took 5 years for people to realize that actually it increased the risk for mortality in women because women were not a part of the trial, and that data was not looked at from a gender and sex disaggregated lens. Similarly, if you look at studies, someone's already referred to this, but there are several studies to show that conditions that predominantly affect women and are a leading cause of mortality, disability in women are underfunded compared to all conditions, not just conditions that affect exclusively men. So there is a need to do more, and I think it's brilliant that we have so many stakeholders here who are passionate about this issue. I'll speak to some of the work that the Bill and Melinda Gates Foundation has been doing and are thinking on this area. So till recently, as has been alluded by Dr. Vinita, we were focusing on maternal, newborn and child health. And this is simply because the maternal mortality rates, under 5 mortality rates were so high, and there was such a large burden of morbidity due to these conditions that these were immediate tractable problems that the global community came together to solve. And we know that the results have been pretty dramatic. But now we've changed our focus to look at women's health more holistically. And we have a division within the foundation, which is called the Gender Equity Division. And this focuses, of course, on health, but it also focuses on agency, on women's economic empowerment, and on leadership. So one of the things we've done this year is we worked with the National Institutes of Health. And as a part of the Innovation Equity Forum, we've launched a Women's Health Opportunity Roadmap. Now, this roadmap identifies about 9 different areas where there's a serious need for action on women's health and women's R&D. And it really starts from things like data. We don't have enough gender and sex disaggregated data in any research that we're doing to really inform new product innovation, to understand policy. How do conditions affect women differently than they affect men? There's very little work on conditions that affect women exclusively. And so there's a lot that needs to be done. So there's data, there's R&D, as I said, clinical trials, outcomes. How do you look at it from a gender lens? Social inequity, regulation, how do you strengthen that? How do you strengthen focus on NCDs? So as I said, cardiovascular is experienced differently by women, so are autoimmune disorders, so are mental illnesses. So there's a need to really look at what's going on and look at it more comprehensively from a gender approach. Some of the things we've been doing is, so the way the foundation works, especially in most countries where we have offices, is we work very closely with the government on national priorities, and we work to strengthen domestic institutions and domestic capabilities. So, for instance, last couple of years, we worked with the Department of Biotechnology to support the development of a cervical cancer vaccine, the HPV-4 vaccine, which got approved last year. We're also doing a lot of work in anemia and nutrition, and there is an overwhelmingly large percentage of Indian women that are anemic, and so we're really looking at systematically how do we improve this. And to build on Dr. Pasna's point, we are trying to do a lot at the level at which women do not have access and do not have agencies. So we work very extensively with self-help groups. So these are community level institutions where we feel that having institutions led by women, which are peer, trusted, where there's women coming together as a collective, these offer very important forums for exchanging information on health literacy, health awareness, empowering women, giving them access to credit, giving them access to loans. And all of these things actually have very positive influences on women's health. I'm also going to end by saying that this is not, of course, I'm preaching to the already converted. Women's health, women's innovation need focus. They need focus now. Healthier women lead to healthier societies, healthier families, healthier communities. But even if you look at it from an economic returns play, there's a lot to be gained from investing in women's health. There's data to show that an investment of about $300 million today can generate about close to $13 billion in economic returns just for the societies by focusing on women's health. So I'm really excited that Ficci has organized this consultation, and thank you so much.
Thank you very much, Amrita, who is the Senior Program Officer with Bill and Melinda Gates Foundation, focusing on innovative health tools. And I think that we're very grateful to the Bill and Melinda Gates Foundation for the investments they continue to make on gender equality. Mrs. Rolly Singh, I would love to invite you now to give your opening remarks. Thank you.
Not exactly opening remarks now, so
halfway through remarks.
So thank you so much for having me here. I would like to thank Ficci for organizing this. This is always, there is never really a special occasion for discussions like this. They should always be, it should be a continuous process, because through iterations we learn from each other, and we learn on what is happening, which is right, and what is going wrong, and where do we need to make course corrections. There were a lot of anecdotal recounting of what it means to be a woman and how women are feeling, but I feel there is a certain paternalistic tinge to this whole thing when we are always harping on women empowerment. What does empowerment mean to every woman is very, very different. And we are nobody, either sitting on the dais or sitting across, to decide what women empowerment means. Because for every woman, it's very different. You can start talking to an adolescent girl today and looking, and despite what economic background they come from, or what their educational background, you will find them very, very sure and clear about, in many ways, of what they want to do, given the right opportunity and given the right, environment. And the whole idea is not, I can tell you about the various schemes and programs that government is running, but I'm sure everybody in this room is aware as to the huge amount of thought that the government is putting in the idea of advancing women's rights with regard to access to health care. And it starts from a very early age. We are also looking at adolescent health. We are one of the few countries in the world to have an adolescent health program. And there is definitely a need to do more gender disaggregated analysis of our programs, because sometimes they are completely gender neutral. For example, NCDs you spoke about. NCDs is a rising problem, and we have recognized that, and we have dedicated programs to deal with the issue of NCD. But yes, there has to be a gender lens in this, and that is a very important thing that has been pointed out. And definitely data is something that needs to be mined a lot more scientifically and more in a more robust way to understand where we are headed programmatically, as well as from the outcomes perspective, as whether the programs are really outcome driven, or they're mostly targeting numbers and just doing screenings, and whether screenings what is the end goal of the number of screenings that are going on. So there are a whole lot of areas where health is facing both challenges, which are mainly in terms of where women are not coming forward to seek that kind of health that is required for them, or the well-being. And you will see that this country, being the country that it is in terms of its capacities across states and the regional disparities that are there, we see that states which are doing well on health parameters are the states where the women are educationally better off, economically more empowered, and they come forward demanding those services. And hence the services are also having to keep up with the with the requirement and the demand, because there is a demand side accountability pressure which is very, very essential for any public health service to do well. Nothing can be supply driven, but unfortunately we are mostly supply driven in our thinking. We decide, okay, fine, women need this. We decide in a setting like this that women need this, and we design a program. But how much of it is actually taken up by women depends on the agility of the health service delivery system of that state, and also the way people come forward to avail those services. So it's a very organic relationship of demand and supply that has to, and that optimal balance many a times is not achieved. As we see in the states in the north, where there is a problem of huge population burden and the public health systems not being that strong or robust. But things are changing very fast. You will see from the way the health and wellness centers, which are the sub-centers which have been upgraded to health and wellness centers, how that has transformed the landscape in the rural India in the north, especially Uttar Pradesh and Bihar and Madhya Pradesh. If you go around, you'll see how people are now coming. Otherwise, sub-centers were areas which people used to avoid. Nobody used to go to a sub-center. But now when you look at the look and feel of the sub-center has changed. The placement of a CHO, the community health officer in a sub-center, has changed the entire way the sub-center is viewed now. It is a health and wellness center now. So how you are branding and positioning your health services is also making a lot of difference. So it's not only schemes, it's the continuous provisioning of primary health care that is going to change the way we look at things when it comes to health. And what you pointed out from the BMGF side, the community outreach activities that have been taken, that should be continuously taken up, are absolutely essential, because people need to be sometimes told what is it that is available for them. Many times government is not really able to communicate right down to the last mile as to what is really available for the women. But a lot of work is happening, so the synergies with people who are working with communities and within departments is what is going to make the difference. So again, coming back to how things are different across the country, I've seen where ICDS and health work closely together. Things are very different on the field. Where the Ashas and Anganwadis are working together, things are very different, because people, then there are, these are the two key field functionaries who need to really come together and look at the family and the household as a in a comprehensive, integrated manner, and that's when services get delivered better. So all the maternal health programs that are there need to be working synergistically together at the level of the ICDS and the with the ANM, Ashas and Anganwadis, doing things together holistically. So we should not kind of take away from the importance of maternal health programs, because we need to have a continued focus on those. We still have to reach the SDGs, and I think going by what we've already achieved in terms of reduction in maternal mortality, I think we would be there very soon. We have already, most of us have achieved our, the target is to make it less than 70 per live birth, and we have reached 97 as per the SRS 2018-20. So I think once the new data comes out, I'm sure there is going to, because the whole lot of there are a whole lot of programs which are also targeting the problem of nutrition, which is being faced by women who are, especially the younger, the pregnant women who are young in age, who are not really mature in that sense. So, but then the education department, ministries, and the ministries who are looking at the overall social reform fabric, they all need to converge, and it is happening very fast, because we are living in an information age where people have access to so much knowledge and information. Women by themselves are opting out from marrying early, and families are realizing the importance of educating girls. You can see it from the enrollment rates that have gone up dramatically. Girls attending up to middle school has gone up dramatically, of course, and the whole issue of women dropping out at a certain age in higher schools and not going for higher studies was one of the reasons, was toilets, and that was something that was pointed out by our Prime Minister himself when he came in his first by Mr. Dharmendra Pradhanji when he was in a recent meeting. He said they were all shocked. In the first meeting ever that he has held with his cabinet, he said, "I want to build toilets for girls." So there is an understanding on why, the reasons why things had not worked so far. We had missed out these very simple pieces of the jigsaw which had led to girls dropping out, not understanding the menstrual health management issues that they were facing. And so we are on the reform path, and we have made huge strides, and we need to continuously engage with all kinds of stakeholders. There are a lot of innovations happening even in providing diagnostics, and so many of you here are from the private diagnostic area. You should understand that there are tie-ups that are taking place for providing the kind of diagnostic care which is required at the time of the ANC checkups, which was sorely missing in our states. Like Uttar Pradesh, for example, has gone in for a huge tie-up with the private diagnostic labs for ensuring the first and second and third ANCs being done on time, because the facilities were simply not there in the rural areas. Plus the PCPNDT Act also somewhat comes in the way of a free kind of a system of practicing this thing. But that apart, we can't we cannot take away from the fact that a lot of efforts has gone in from the government side, as well as the state government, especially where this whole action is taking place. I keep reiterating that it's not the schemes that we design, it's how they are implemented that makes the difference. It's the whole proof of the pudding is in the eating. And every state is doing it in its own way, depending on its own capacity, and they're putting in a lot more than even what we are provisioning for from their own side. So there is a lot of investment in health, and there's a lot of realization of the importance of women in this whole thing. And a lot of it has to come from women themselves. So that requires a different kind of
push from all other sides, which is be it education, be it social security, be it providing them employment, livelihoods. So it is a 360-degree thing. Health is not something that can be, tackled in isolation. So I think from my side, I would like to end there so that you can open the house for further discussion.
Thank you very much, Additional Secretary. And I think really for emphasising the diversity within India and the fact that there are amazing strides, but there are still areas that need work in order not to leave others behind. So that it's been a really nuanced overview, I think, that's very useful for us all. And I believe that we're just going to have a formal thank you before proceeding.
Thank you very much, Suzanne, and thank you, Mrs. Rowley, ma'am, for your valuable remarks, and glad to know about the various programs conducted by Government of India for the betterment of women. And now, we request Mrs. Rowley Singh, ma'am, to release the position paper on empowering her health, which has been developed by UN Women in partnership with Ficci and Apollo Hospitals. This paper release will be followed by a series of discussion forums on the significance of women's health. We shall submit further recommendations on the same after that. Thank you, ma'am, and thank you, ladies, for taking the time out for the release. Thank you very much. And I now request Susan to kindly take forward the discussion. Thank you.
Thank you. So we have, as I said, a number of women on the panel, and there's others actually sitting in the front row as well that I will be calling on from time to time. And I'm hoping that at the end we will also have time for questions from the floor as well. So turning first to Dr. Sunila Garg, who's the chair of the Program Advisory Committee in NIHFW. And Dr. Garg, can you tell us the importance of women's health in your view and their uninterrupted access to health throughout their lives? Thank you.
Thank you, Susan. It's a very, very important question, because today when we talk of, we are not talking of, few women, we are talking of 60 crore women. And when we talk of 60 crore women, we talk in terms of their health survival, we talk in terms of their economic opportunity, we talk in terms of their participation, academic achievement, and political empowerment. And when we talk about these women, we talk right from conception, that means from, birth, conception, birth, and we talk from, the stages of growth and development, and most important being period of adolescence as well, which is, I'll talk from my experience, because I was involved in framing this adolescent-friendly health services program, which unfortunately is not in the form which we had planned. And the monitoring and evaluation showed that it lack of its functionality. And I carried out a menstrual hygiene project somewhere in 1993, and now in the year, when we talk of 2020, not much has changed. School absenteeism is still very high. The schools do lack toilets and all that. They do not have enough facilities, but government has invited suggestions for improvement of this. And please give your suggestions. Those of you, can do that. Ministry's website is already open to that. And then, I'll talk of one of the practical examples. In 1986, we started talking of feasibility of involving existing infrastructure in early detection of precancerous and cancerous lesions of uterine cervix. So, and at that point of time, the things were different, but now, the things have changed. We can make effective use of our 3 A's, that is ASHAs, Anganwadi workers, and ANMs. So our ANMs are fairly capable of diagnosing along with CHOs, provided they are adequately trained. And when Dr. Arvind Lal talked of smart PHCs, so that is where we can do the capacity building with regard to, when we talk of ANMs, so that early detection of lesion is there. But please remember, we have to take the communities into confidence, as Madam Rowley Singh pointed out. My own experiences, in the community when I was working, as a young officer, and now, at an older level, we need to change the mindset of the community. Couple of times when the women were on the table, they were taken down by the men. Why did you come for examination? Because one of the women was found to be VDRL positive. We said, you will be getting treated and your partner will also get treated. So they said, why did you first of all come for examination? So that is where we need to change exactly the mindset of the people. That is one thing which is very, very important. Another thing I like to say in context of menstrual hygiene management, we need to be much more open and we need to talk about the latest devices. When we talk of, only, sanitary pads and all that, in 1993, Hindustan Liver approached me and they said, ma'am, yours is the only paper which talks of myths and misconceptions with regard to menstrual health and hygiene management. And we want to have an event, and that event was very high profile event, called from my, young, I'll say officers' perspective, they called Shraddha Kapoor, they called all range of, all the actresses and all to promote Whisper sanitary napkins. So to my young mind, I thought that it is important that, at least, people are going to use pads and all that. But, now also I'll say that, we need to think of environment part also. So that's where Ficci can play a very, very important role, in Confederation of Industries. We need to promote more of menstrual cups. And now I know that, there are a lot of women who are using these menstrual cups, which are very cost effective, which are, costing only about 400 plus rupees. And plus, they can be washed and reused. So we know that many medical students, many engineering students, many of the homemakers are also using this. So we need to empower women with the correct knowledge. And first of all, we need to empower ourselves with the correct knowledge. And another thing when I went further was, and if all of you, I don't know how many of you know about Rani Bang and Abhay Bang's this thing. Rani was my registrar, and she brought out to the global community that Indian women, they carry a high burden of reproductive morbidity. My own study in Maulana Azad, when we did the examination of women, we did the field test along with gold standard test. For every test there was a gold standard test. Okay, so that brought out that 68% of our women are carrying high burden of reproductive morbidity, and that's where the scenario still needs to be kind of focused upon. And when we talk about smart health and wellness center, we must make sure that when women are accessing any of the healthcare facility, whether it is primary health center, whether it is community health center, whether it is a higher facility in terms of sub-district or district hospitals, they need to be asked about their health in totality, because we are well aware of the fact that a simple vaginal discharge is never perceived as a kind of a problem by the woman, that because she is virtually asymptomatic and she doesn't bother to consult the healthcare facility. So that's where it becomes very important. And now there is a huge burden, and all of you would be watching that Wagle Ki Duniya, that there is a serial which comes in and where the woman is talking about, breast cancer. So I have seen the times changing from cervical cancer to, breast cancer taking, a higher, prevalence, and we need to focus upon empowerment of women in terms of correct diagnosis and self-examination. And that will only be possible when we tap in all the resources across the country. We know that we now have very good models. We can empower our healthcare workers, and ICMR has funded many projects with regard to this, and we need to kind of look upon that and see that every woman at least is empowered to look at that with regard to breast self-examination. Another thing which Madam Roli Singh pointed out is the huge burden of NCDs, and now we have put in an implementation research with regard to integrating mental health along with non-communicable diseases, and this is an implementation research. Please, I will request all of you also to focus more on the implementation research. That means from the beginning, government is going to be there with you. So at the end of the project, you don't, see that how the sustainability is going to be there. So that part becomes very, very important, as mental health is also another major issue, which is, kind of, which goes unnoticed. And this is where we need to focus from the gender perspective. Now, we are not very far away from sustainable development goals. And not only, we need to focus on goal 3, but we need to focus on zero poverty, no hunger and all that, and see that women do not go, kind of, not only, we see that huge percentage of women, are 24% are malnourished, 58% are, suffering from anemia and all that. We don't want that situation to be happening in 2030. Time is now. Time is to focus on, when we talk of नीली गोली, we talk of लाल गोली, सारे अभियान जितने भी हैं उनको हम true spirit में आगे बढ़ाएं. So that will be very, very important part also. And also, we know that we have sufficient number of programs. As Madam said, that Roli Singh, she pointed out that we do have, right from Janni Suraksha Yojana, that means mother's protection, or Janni Shishu Suraksha Yojana, or respectful maternity care, or when we talk of Lakshya, labor room quality standards initiative, or Surakshit Matritva Abhiyan, Suman, what we call it as, and Prime Minister's absolute affection, where every on 9th of every month a woman will be provided check free of cost. So that is also very, very important, and we need to equip ourselves, and please disseminate this knowledge to everyone, because what is important is programs are there, but their implementation is the one which needs absolute attention, and we need to focus on that part also. And then that Pradhan Mantri's that Matribandhan scheme, where a woman is entitled for cash benefits also. And then when we talked of toilets recently, my very recent visit to Jaipur, because in community medicine we tend to allot the families for examination of students, they tend to go to the families and then they take the case. There was a toilet in front of, within their house. I said, now it would be very good for you that you use these toilets. They said, no madam, this is only a decorative toilet. We don't believe in these toilets. So somewhere, it is not only important to have toilet, but it is important to make them aware that it is important to use these toilets, because if you are going to wait from morning to evening, you are going to suffer from whole lot of urinary tract infections, reproductive tract infections. So all this correct impartment of knowledge is also very, very important. So I feel that apart from the concept which you really brought out is the concept of smart, PHCs, we need to focus a lot on, awareness creation, education, universal access. We need to also focus on health technology. That is where it is, and health technology was something, in COVID times it really helped us. And, we also have to keep in mind that for any problem, women are not only infected, they are also affected by the problem, which COVID, showed us. If women suffered from COVID, she was also, taking or not taking care of herself, but she was worried about what is going to happen to the family, and I have to, take care of the family in terms of their food and all that.
Dr.
Another thing which is
Dr.
also...
Garg, sorry to
I will
interrupt you,
understand.
because you have so many important points to make, and
Thank
so
you.
I'd love to come back to you.
Yeah.
But just for the moment, I think there's some other questions as well that would be good for people to talk about. But
last line is
thank you.
that together we can do more. Thank you so much.
Yes, thank you. Thank you very much. And also for raising some of the basic issues around poverty that remain and that still need to be unlocked. So, Dr. Tanuja, just turning to you, because you have a different perspective, I think, coming from the Ayurvedic tradition. So please give us your thoughts. Thank you.
Thank you. I think the role of woman in a family, I consider the role of Ayurveda in the healthcare system. It is last but not the least, very important. So thank you very much, Ficci, and thank you very much, Susan, and Roli Singh and everyone, highly accomplished woman on the panel and empowered woman of the dais. So thank you very much for considering Ayurveda as a very important pillar for achieving the holistic health, as everyone is talking about the holistic health and reaching to the last mile. I think the integration with our own tradition is very, very important. And for that, there is a separate Ministry of Ayush. As parallel, we have the healthcare system, we have the infrastructure and many others in place as compared parallel to the conventional medicine. And as mentioning about the women's health, what Ayurveda is a knowledge system of health and happiness. So when we say that it is the journey is from illness not to wellness, as we are talking about the preventing health, but what we try to achieve is journey from illness to wellness to happiness. So if woman, we not only woman but everyone, if we achieve holistic health, it is a mental, physical, spiritual and social well-being, and that's the true happiness. If we achieve, I think that's how we make everyone, the society, healthy. And how do we do that? The Ayurveda
advocates because prevention is the strength of Ayurveda. Swasthasya swasthya rakshanam. So whatever more focus is on preventive, promotive health and maintenance, and even on the primary health care with home remedies, the local herbs and many other things. But most important is the diet, lifestyle and the true rest. Three pillars of the health is the ahara, nidra and brahmacharya. That is a holistic diet, lifestyle and the rest. I think everyone, if we really focus, and women are really empowered, because our Prime Minister Narendra Modi ji says now it is not only woman empowerment but woman led empowerment. So if every woman, they are the leaders, I think we have to empower each and every woman who is in as an employer, as an employee, or whosoever is our, we really have to empower with giving three basic things. It's a diet, lifestyle and the proper rest. And diet, when we say that, Dr. Susan, it is a SDG and we are talking about NCDs, prevention of the NCDs, the root is in the diet. So till now, India, after independence, we were talking about food security, but now it is a high time to talk about, create awareness, education, skilling about the nutritional security to each and everyone. And it is the nutritional security is not only for the poor, but it is not only for the rural, for the urban also, because creating awareness about what is the holistic is very, very important. It is not only carbohydrate, protein, fat, but holistic, what everyone tells us, what is good for me, for the season, for this local region. So we say that आपके दादी माँ नानी माँ जो ले रही थी वो आपके लिए अच्छा है. So what is traditional food, what your local food, your traditional healthy food is good for you, because your genome is really nurtured of that. And that holistic concept needs to be available on the plate of each and every woman at right time, even in the office time, during the early and during dinner also. And that should make very important. And as you said that your paper says that everyone's, this is a woman's health is woman's right. But what I see that when we say that woman-led empowerment, woman empowerment, we have generated one program, we call it as a My Health is My Responsibility. मेरा स्वास्थ्य ये मेरा अधिकार नहीं है, मेरा स्वास्थ्य ये मेरी जिम्मेवारी है. It is my responsibility. And if every woman considers it's my responsibility, I think entire family's responsibility she can take and everyone can take. And the lifestyle, because urban woman's problem is sedentary lifestyle. So if at least 30 minutes walk, yoga, Ministry of Ayush really emphasis on even 5 minutes yoga break. At least in office you can do. 30 minutes walk we can do, morning, evening, after. I think this needs to be very, very important, not only for the adolescent, early catch them young is very important, because exercise and vyayam should become the habit of everyone's lifestyle. I think very, very important. And I think these are very simple things that those are cost effective, that does not really need any economy, that it becomes the awareness and the education. And school education, like it is PT, physical training, but that yoga and the vyayam and exercise needs to be very, very important. And the rest, very importantly, 8 3s are 24. That is 24 hours day. If we divide into 8 hours profession, 8 hours rest, and 4 hours morning and evening is your family, individual hobby and everything. I think that's the key of achieving the holistic health. So we are creating a lot of awareness through Ministry of Ayush, through the school education, various programs in the college education, and through Health and Wellness Center, HWC, 12,500 HWC, through National Ayush Mission. Those preventive health programs are being implemented at the grassroots level. And just as All India Institute of Ayurveda, which I am heading, is for creating the data, creating a scientific evidence to our classical wisdom. So we have so far treated as a tertiary care hospital 1,700,000, that is 17 lakh patients with holistic and integrated management with conventional outcome measures for each and every disease area, 42 specialty units. So we have the data, documentation. If you ask NCD, so I can give you 60,000 diabetes patient with HbA1c pre-post with the holistic Ayurveda diet lifestyle intervention. So this data where we say that the holistic intervention really helps to bring out the better outcome when we integrate with the conventional medicine. And in the women's health, as public health initiative of Ministry of Ayush, All India Institute, we have initiated what is our tradition. It's called as a Garbhini Paricharya. During earlier days, 9 months there was a तीसरे महीने में, चौथे महीने में, पांचवें महीने में, what the antenatal care is to be offered. So we did it scientific study on public health initiative as a Garbhini Paricharya, and 10,000 women in the rural area, they were screened, and we selected 1,500 women antenatal care and gave them followed completely from first conception to 9 months. And what is the scientific, because that was been analyzed scientifically with research question and statistics. So what is to our surprise, what we observed is a zero mortality. And LSCS, that is a cesarean section, out of 1,500 only 3 had to do the LSCS. So that is the that is the importance of following our traditional antenatal care and postnatal care. And in pregnancy anemia and even the woman's anemia, simple measures from Ayurveda intervention like Dhatri Loha, because now we have introduced in the NAM also through Ministry of Ayush in the policy. So that really helps in really bringing out the anemia. And IUGR, that is intrauterine growth retardation, when we added Ayurveda simple intervention and with nutritional security, so average 0.5 birth weight, baby's birth weight, we could get the increase in that. So what we say that the future of the medicine is no medicine, but what is the future for the outcome is the future of the medicine is in integration. So if tradition supported with the technology and the science, and tradition supported, integrated with the conventional medicine as a complementary medicine, as WHO also says that we have to harness the potential of the traditional medicine of the local countries. I think that is the way how we prevent the SDGs, how we prevent the NCDs, and how we improve the women's health as a whole. Thank you very much.
Thank you, and I think that you've really reinforced some of the previous comments about that women's health is holistic. It includes so many different aspects, from the highly technical through to the commonsensical, and then, you know, basic understanding of health and how to look after ourselves and our families. So thank you very much. I really would like to know more about Ayurvedic medicine.
Thank you. You are most welcome to visit All India Institute, everyone.
Thank you. Thank you. I will. So now just on to a completely different topic, and this is, I'll introduce Ms. Shobha Mishra Ghosh, and she's the Director and Head of Government Affairs and Policy in GE Healthcare. And really now we're looking at the sort of higher tech side of healthcare, and how can that play a role in increasing women's access to health?
Thank you, Susan. Thank you all for a very animated discussion. So I think one thing is emerging very clearly, that when you are talking about women's health, it needs a lot of orchestrated interventions. Not just, you know, access to healthcare, it's about education, it is about empowering to make a choice. I think I go with what Madam Roli Singh said, that who are we to, you know, talk about what is empowerment, but every woman should be empowered to make a choice in their life. And that is what today perhaps, even amongst the educated women, that's, you know, we are probably 0.1% of privileged women who are sitting over here. and making that. So, there are a lot of surveys, I don't want to go to, go into data, that says that, compared to men, access to healthcare for women is a challenge, right? So, and particularly as you go towards the tier 2, tier 3 rural areas and remote areas, it becomes more and more challenging. A man can travel to the city and get himself, but not a woman, because the entire household gets impacted by her moving out for that one day. So what as a society, as a government, as healthcare providers, we can do is to make sure that the technologies that are available today are accessible and are within reach of every woman who lives in that last mile. Ma'am, you mentioned about PCPNDT and you did kind of touched upon the challenges. And that's particularly what I wanted to talk about it, that ultrasound unfortunately has become a kind of a infamous medical equipment because of the female feticide that we see in our country. And therefore the PCPNDT Act was brought into fore, and we do all acknowledge that there is probably a need for this today. And we have the unique distinction of being the only country with this kind of an act. So definitely we need to work on bringing in the change in mindset, so that from a patriarchal society, where we look down upon women, we come to a equal, equality for women. And we do understand that PCPNDT needs to be there in our country, maybe for next 20 years perhaps. So the challenge today is that ultrasound machine, 30 years back was only maybe for use for maternal care and obstetrician, but today technological advancements have gone so much further. There are so many doctors over here, they probably will all endorse that it is a low radiation, easy to use, easy to handle, easy to move kind of a medical tool that is used for detection, diagnosis, treatment, monitoring, post-monitoring, etc. And it can detect cancer, CVD, liver issues, etc. However, the PCPNDT Act becomes a deterrent because the implementation of this act across the states is very uneven, and not only across the state but across the district, because the interpretation of the act is dependent on that local block officer who is probably implementing it. From the industry side, we have been working with the government, through trade association bodies to take this fact to educate, the multiple use of ultrasound machine. And even in countries like Africa, you go to Uganda, Kenya, it is very widely used, and the necessity for using this actually became apparent during COVID, because when interventions were happening in the ICU, we actually didn't have doctors who could use ultrasound machine in the ICU, because the radiologist would not go into ICU, and critical care specialists did not know how to use an ultrasound machine. So that is where the whole issue actually became more apparent. Ma'am, we have two suggestions for that, to make it more accessible to rural and interiors of the country. A guidance to all states that streamlining of implementation of PCPNDT should be there. It should be uniform, so that the healthcare provider, the doctor, and the medical technology providers, they are all in the same page, and there are no delays, because the delays today in installing, you sell a machine, the installation can takes anywhere between 72 days to 720 days. And the other thing is, since we are, into the digitization path, and there is National Digital Health Mission, if we can initiate a rule-based digital governance mechanism that not only tracks the machine, but also tracks the scan, so that, you have the you can track both, and therefore there is more transparency, individual interventions get reduced, and it's I think it is also better for the policy makers, because they would know where all the details that are required to be known. So that's my humble submission.
Thank you very much, Shobha. And ma'am, I wondered if you wanted to respond to that one.
These are very logical suggestions, and we have also felt that there needs to be some calibration of how to balance the requirements of sex selection, the dangers with sex selection, with the need for a good ANC for services for women. So and I think any logical suggestion which comes from the industry side or from the side of any public-minded body like Ficci will be taken seriously. I think if you'd come out with some sort of a note on this, I think it can be taken up with the right quarters in the ministry, and it will find some traction there, definitely.
Thank you. Thank you very much. So now turning to Dr. Sabyata Gupta. Hello, I haven't met you yet either, so it's a great pleasure. And so Dr. Gupta is a chairperson in the Department of Gynecology and Oncology, Medanta in Gurgaon. And I believe that you were the first robotic gynecologist in India and to perform robotic gynecological surgery for cancerous and benign
That's perfect.
conditions.
Right. Yeah.
So, please tell us about your sort of journey, what you've learned from this, what we can all learn from this as well. Thank you.
See, this is a very high-tech kind of a thing. When we talk of robotic surgery, of course, I think everyone should be lucky enough to reach this level and have an access to this high end of technology for the treatment. But I wouldn't mind saying that we all agree on that of course, we have to begin with, we have to create an awareness and realization amongst all the ladies and in fact all the family members and the society that yes, women's health is the most important, the most crucial thing in the society. That is one. And second is that we can have a social media campaign wherein we impart correct information. It's not just the information. My stress is more so on the correct information. And that should be regarding all kinds of health, be it adolescent and menstrual health, be it maternal and child health, be it reproductive, sexual health, mental health, general medical health. So it should be a very correct information available so that the whole family, the whole population of India or worldwide, I'll say, should have an access to the correct information so that they know when to report. Not that, you just sit at home and you think, oh, it's normal to bleed heavily every month. So they need to know, they need to have a correct information so that they have an access. Then, of course, I think something like an annual checkup for all the ladies should be mandatory, whether they are sick or not. All the healthy ladies should also have an access to annual checkup. And then these are the basic ones. And then, of course, everyone has the right to have the best treatment. So there comes the role of technology. Yeah.
Thank you very much. And actually, Vanita was just telling me that Dr. Aparna Dar is here, and I know that you also work in oncology, I think. So please feel free to add in.
Sorry, good afternoon, everyone. Really interesting insights, and what really got my attention was, as I think one of our speakers spoke about breast cancer awareness, and this being Breast Cancer Awareness Month, that even when we talk to our survivors, there's so much shame and taboo around the fact that they had breast cancer, and especially if something is genetic and it's going from one generation to another, nobody wants to discuss and have these conversations just because it's considered, oh, it's coming from the mother. Unfortunately, it's not always from the mother, it can be from the father too, but there's so much misconception, and this actually stems from the fact that none of us actually talk about it. We don't want to talk about breast cancer, we don't want to talk about ovarian, endometrial cancers, cervical cancer. You have a vaccine which actually is a cancer that you can't prevent. So I do feel that there's a lack of awareness, and this awareness starts with professionals as ourselves who actually need to go into the second tier, third tier cities, into our rural areas, and actually have these conversations and try and negate the taboo that comes around with these women-associated diseases. So it's really refreshing hearing these conversations over here, and I really hope that all of us together can help implement, because early detection can lead to a cure for cancer. It's not always morbid. It doesn't always lead to death. So just my 2 cents.
Thank you. And I think both of you have really highlighted this issue again of social norms and what is acceptable to talk about and what isn't acceptable to talk about. And interestingly for me, being non-Indian, the country I'm from, women are better at seeking health than men. And because there's a social norm there about it's okay for women to talk about health issues and need things, whereas the masculinity is around, I don't need any help. So that really plays out in a completely different way. But I think you're absolutely right. And again, in India, it strikes me that India is a country where people do talk about menstrual health and hygiene. And in my own culture, which is Australia, that's still quite rare. So for people to talk about menstrual poverty, for example, that's a very new concept in other countries. So much of what we're talking about is underpinned by our social norms that we all hide inside ourselves, which can change. And often change quite simply by information and discussions between men and women, girls and boys, and women and women and men. So thank you, both of you, for raising that again. And I believe we have Miss Anuradha Gandhi, who's a lawyer. Yes. Would you like to talk a little bit about health from your perspective as a lawyer? Some of the things that are working to help women access and things that are not.
What I would really like to talk about is, there was a very recent case on a woman being allowed or not allowed to terminate a pregnancy. Okay, it was very widely debated upon, and in fact, the first order that was passed in that case was the woman had been allowed. And then one of the doctors at AIIMS, he said that if we allow that, you are telling us to basically stop the heartbeat of the child. Are you willing and are you giving us the permission to do that? So the case was called back. It was again debated upon, and finally it was disallowed. And the woman also finally agreed. She said that, no, I do not want that to happen. Well, let me give you a bit of a background about the woman. Why did she go for this medical termination? Reason being that she already had 2 children. She was suffering from a postnatal depression, which is very severe. In fact, it was debilitating to the effect that she thought that she cannot handle another child. Secondly, the economic condition of the family was not that good that 3 children could be supported. Now, if we look at the law, the way law stands, there are a couple of things that, up to 20 weeks you can terminate the child, the termination of the, not the child, I'll not say, but termination of the pregnancy. Post that, you need certain medical practitioners to intervene and give you the, the write-up that you are allowed. And then after 20, it follows. But under the law, you also have that in case you're a victim of a rape, you're a minor, or there's a severe danger either to the health of the woman, a disability, or the fetus as it stands suffers from a disability. Then you're allowed to terminate. But there have been such contradictory judgments, so I don't know what really to say, because there are certain high courts who have not allowed minors to terminate a pregnancy, and this present judgment that it has come out, it has again sparked off this debate. So I don't know what really happens. We're just waiting, and it can be said that the facts of the case were that they felt that what really should be done, there's no clarity about it. So I'm just hoping another case comes up and some kind of guidelines are passed about this, and we'll see. Because world over, India has been very progressive as far as termination of pregnancies is concerned. Because even if you look at the US, Roe versus Wade was overturned last year, and about 26 states have said that yes, we are not going to allow you to terminate a pregnancy. And in contrast has been India, which has been allowing that. In fact, I don't know if you guys remember, a few years back there was a case in Ireland where an Indian nurse died because she was not allowed to terminate the pregnancy, and after that they started allowing the termination. So along with this, we have the Maternity Benefit Act, which goes alongside, and women are given certain, financial benefits as working women. 6 months of paid leave and certain other benefits. And even if they lose a child during the birth giving process or any other reason, they still get some benefits. So there is a lot of contradiction in law, which I think a clear policy needs to come out from the government as to what needs to be done. And another thing which I really want to talk about is the menstrual policy and the menopausal policy. There were certain public interest litigations filed in the Supreme Court, with the court dismissed and said that the center cannot really intervene in it, and the private organizations should actually form their own these policies, the menstrual policies. And some of the companies have come out, some educational institutions, some bigger corporates have come out, but unless a clear policy comes out, nobody really is going to follow. We are leaving it to private individuals' whims and fancies as to how and what they would implement. Now, the other thing that all the women out here on the panel have been talking about is menopause and the health issues concerning menopause. Legally, we do not have a menopausal policy which can be implemented. Women cannot ask for any benefits, and they cannot ask that if we can take a leave, or we can ask for an extra insurance for our menopausal issues. So these are some of the concerns which I feel that government needs to look into and needs to have a clear policy on.
We look towards the judiciary for a lot of these directions. So I place it back in your court. Come out with a judgment and we'll follow.
I think what is going to happen is then the courts are going to be called proactive, intervening too much into the legislative process. So I think
actually, you see, there is again, it's a thing to be decided whether menstruation is a health issue or it's a physiological issue. We should not make it a health issue if it is not. But we should definitely, look at it from the point of view when it becomes a handicap for a girl to lead a normal life, or even access education, and so that's where we step in when we come out with schemes on management of menstrual hygiene, like we did in Rajasthan. Maharashtra did it before us, and that the whole idea was to ensure. It was more of it came from the women empowerment side. It didn't come from the health side, by the way. It was housed in the women empowerment department of the Women and Child Department of Directorate of the Women Empowerment, which was under Women and Child Department of Rajasthan government. So, it's where you house it. If you want to make it a health problem, it'll have a completely different lens. Then we start looking at distribution of sanitary pads. But when you start looking at it as an issue which has to be handled from point of view of, giving her agency or giving her a choice or an understanding, then it gets approached very differently. So, it all becomes a question of framing then. Mm-hmm. So we were looking at that scheme only not from the point of view of distribution of sanitary pads, because that the health department was already doing. We were looking at it from point of view of management of that girl's whole menstrual cycle in a manner that it does not impinge on her normal day-to-day life. So how they can manage it within the resources that are available, and also availing whatever is coming free from wherever. So we had just brought in schemes together where money was available either for IEC or under Swachh Bharat. There was a lot of money for IEC. We had gotten in touch with the education department to make a change in the curriculum where it should be taught as a subject, not as a subject, but as an area of where you have a lifestyle. There was a curriculum on improving your nutrition, your health, and all that. It's more of a social science kind of a thing. So it was supposed to be taught in a free period, which never gets taught actually. So we were training teachers as champions for discussing this problem informally and formally with girls if they required it. So creating a sense. So then later the school health and wellness program came about where we had school health ambassadors. So if that can be, the school health ambassador should ideally be the first stop, where the girl or the boy can approach for issues like this. And they should be aware on handling, answering questions around menstruation, the taboos and the social hesitancy that is there on discussing this. So the school we thought was a safe place where the teachers need to be made, teachers who are willing should come forward and be able to answer these queries as guides and counselors. So, and even for mental health, I think schools should be that place where a child can safely access these services. All the private schools have a mental well-being component now. Why can't we have it in government schools? So that discussion is also going on. So again, coming back to having a policy, so should it be housed in health, or should it be more of a, from the social empowerment side or the women and child ministry side, that kind of a thought has to go into it.
Thank you, ma'am. The other question, menopause, because when I speak to so many of my colleagues, they all say feel empowered at the age of 50 when our household responsibilities are over, but then our body starts behaving in a way that we cannot handle. We are not allowed to take leave because it is more questioned. It is said that maybe you need to, leave the job. Maybe you're not good enough for the job. Maybe you have no energy. So if there is any kind of menopausal policy in place, at least these women would have some kind of recourse to look at. So I don't know how it can be done.
Should it come from health? Because here you're talking about their employable, they're increasing their employability or their conditions of service, basically.
Right.
So like childcare leave emanated from the Department of Personnel and Training, and that was as a result of a whole study which was conducted on women in civil services. It was housed, the Lal Bahadur Shastri Academy of Administration, Mussoorie, had done that study under the leadership of Madam Sarojini Ganju Thakur, who was a full-time gender expert, though she was in the IAS. So she did a whole what is it called, a chronological study of how a woman in civil services spends her time vis-a-vis how her counterpart, male counterpart, does that. So it was a very, it was a proper study with proper questionnaires and with all the kind of research rigor, it was conducted, and it kind of proved the fact that women were far more stressed for time than their male counterparts in the civil services because of this additional burden of the responsibility of taking care of the child, which normally falls on women. I don't know what the situation is now, but that time it did. And there was a lot of, had to be a lot of lobbying around it that had to take place. And so once this report came out, it became the basis for provisioning of this childcare leave. But that's only in government. How many private people have taken this up? So everything can't be just meant for people in government, if we really want to put our money where our mouth is, we should do it in the private sector as well. So all of you who are representing the private area, how many of you are really willing to understand and promote that diversity by giving women that kind of a flexibility where they can take care of the children. There has to be certain compensatory leave given to women when the child is appearing in, say, class 10th or class 12th, or when they're sick. That's the time most of the women take leave, when the children require, them to be around for their studies, for their board exams, when the stress levels are high. It is a lot of de-stressing for the woman also to be around, so that, because, that time the child is going through a period when they need one of the parents around. Now there is a lot of talk of men wanting to share that burden. So we said the moment women get something, men want to take it, So we are willing to share it with the men, provided they do their job. So that 2-year leave that women get in the entire course of their career till their children attain the age of 18 is something groundbreaking which Government of India has done. I don't know how many countries are doing it, even in the Western world, providing that kind of a facility within the service with full pay. So that kind of security, I think, is unparalleled. I have spoken to a civil servant in the foreign service from the US of A, who had to leave her job when she got pregnant. She had to leave her diplomatic career. She became a trainer and a teacher and everything else. But that's the kind of barriers women face. So it's not an Indian problem, and there are all kinds of problems everywhere. So we should not be denigrating and running ourselves down and say, oh, we women are in such a bad. We are not. There are a lot of good things that are happening here, and there is a lot of social security and social capital that is there in our rural areas, which we should be celebrating, rather than saying, oh, our women are in such a bad shape. They're not. There may be because of economic deprivation and other things and mindsets, but all that is changing, and it'll change. Every generation will have its own set of challenges. It's not as if urban women who are earning really well are really better off, than their rural counterparts. They have other challenges, they have other issues. They don't have that kind of leisure that women in the rural areas have many a times, So I think that point is well taken. Menopause is an important milestone, but everything needn't come from government alone. Okay, we can give the direction, but maybe let's see how many private people are willing to give childcare leave, or even recognize diversity and allow women to work from home in times when they really need it, without coming down on them and saying, oh, aurtein hain, chutti mangti rehti hain, things like that. That's how they talk everywhere. It's not so much in government as it is in the private sector. So, point well taken. Thank you.
Thank you so much.
Thank you. Just an observation on the menopause issue. In some countries, when women go through menopause, domestic violence suddenly shoots up again. So women who may never have experienced violence in their families suddenly start to experience it, and it's partly because of some of the changes around, women's interest in sex. So, which means that husbands often think that, well, she's having an affair somewhere else, because they also don't understand the changes in libido and things. And this, I've seen, has led to an increase in violence. So it's linked to health issues in some ways in some parts of the world as well that are beyond what you would conceive of. So, and it's this area of policy and looking at what is good practice in different countries is something that UN Women would be very interested in sort of working with others here about what is working well, what are some of the innovations in India and in other countries, what can be also considered. So, thank you. And so you wanted to also raise a point. Could you just introduce yourself? I'm sure others know you, but yeah. I don't.
So, ma'am, I wanted to also say something very nice about the women who are born in India. There was an act known as the Medical Termination of Pregnancy Act 1971. So the government of India and the courts in India decided at that time that women in India were fully empowered to terminate their pregnancy at whatever time, and they could just walk into a hospital, not even given their husband's or partner's name, etc., and it could be done. And we are appalled that we're halfway, 50 places around the world, a woman cannot walk into a hospital and demand a termination of pregnancy. So this is something to rejoice about the Indian woman. Thank you.
Yes, I think that, as you said, these laws are incredibly progressive, and actually globally, a lot of these wins are being eroded in countries that had similar wins. So again, on gender-based violence, Russia repealed their law outlawing gender-based violence. So now it's legal for a man to beat their wife. So, so things are being rolled backwards. And this, I think, again, India has a huge amount to offer in this respect of this progressiveness. So thank you for your comments. Vinita, I just wanted to hear any more thoughts for you on sort of health-seeking behavior or behavior change or anything.
So, Susan, thank you. And I think when we started this conversation, I think it's an hour and a half plus, I think we've already reached a kind of a framework that needs to be addressed. So many things have come out. And I'll quickly just make a couple of pointers here. The first is it's been recognized, not just in this room, but otherwise as well, that we need a gender lens to health, starting with families, households, to education institutions, to where we work, to enterprises, and at the national level, we need multiple stakeholders. We need people like us, providers, companies, private sector, medtech companies. Let me just finish, we'll come to her. And then all stakeholders to get together to work with the government in two ways. One is to see how can a policy landscape be there, which is really addressing even the emerging needs that, in spite of Dr. Lal, thank you for that, the MTP Act, these are evolving landscapes. And I think this time always, like Rolly said, for some course corrections to also reconsider areas. And the second thing which has come out to me very strongly is that there's no such thing as a lack of convergence if there's a will. And I'll give you one small example here. As Apollo, we are doing a wonderful project at the global level called Edison Alliance, which is only looking at digital health inclusion under World Economic Forum. Imagine a company like the American Tar Company and Apollo got together, and we are doing in 5 districts of Madhya Pradesh an amazing digital health project, which was not designed towards women, but to combat NCDs and mostly screening and preventive. We found within 6 months, the needle moved, and almost 68% women in those 5 districts have started visiting the digital health dispensaries. And of course, oncology, again, screening was one area which was amazingly, the stigma was destigmatized. And vaccination was another thing that we were doing. And similarly, we are doing the cancer care digital dispensaries in Meghalaya. We're putting up a project in Jharkhand. So these are proofs of concept. They can be scaled up. But the reason they also scaled up was that the state governments joined hands. Because somebody mentioned here, as UN SDGs are being reset, they're being reset with the purpose of leaving no one behind. And the last mile in a public good like public health needs government support. And I'm so grateful to the government for the central government. You see all in this paper, the different schemes for women's health have been addressed. But I think it's at the last mile that we really need to also push this. And it's not to say that we in urban areas don't have issues. We have another emerging huge issue as winter approaches, the pollution, and that really impacts. I saw a study just the other day how the pollutants get into our bloodstream and emerging as a source of breast cancer. So the PM, what is it called, the particulate matter 2.5, and this was. And I come from an undergrad college which is considered prestigious. And I think in our group, everybody was asking me to share that study. Final point here is, I also feel, many of us, I can recognize faces, are from Lady Shri Ram here, and we are all alumni. Rolly is, I am, I think the young lady there is. We started a group insurance policy for our women, and we started partnerships with clinics and hospitals for screening. I can tell you from that sample of 1,000 women in that group, we have seen a jump in women who are now going for screening. And they want to take the annual package to get themselves screened. They're also using the group insurance for themselves as a caregiver for their in-laws or their parents to get the health costs covered. So I think there are these little things, if PPPs can be done, and also if private sector can be nudged in certain ways. I do believe there are gendered fiscal interventions that can be done in a way that private sector comes forward to take better care of the women who are working for them, because for them they won't drop out and the productivity in the enterprise is going to increase. So there is some papers that we have been working on. I think that I'll leave for the next series of sessions. I'm so happy to see the outcome, and I think with this we can really, Ficci team, I must applaud you, and I think we must have a plan now to move to other cities and carry on the discussion. That's all from me.
Thank you very much. Thank you very much. Would you like to make a comment? Thank you. Please just introduce yourself.
Yeah, good evening. I'm Geetika Sahani. I'm from Fortis Healthcare. So my thoughts were exactly what Mrs. Roli Singh said, that spending 5 decades in this world, I've seen the world change for women. My brothers wouldn't have known when I was having my periods. My son did. So maybe to an extent my father-in-law also did, because that change came in. So I come from a family which is more population of men, more boys than girls. So maybe we were the ones who were pampered more. But what I feel is that men take care of us much better than women do. I'm sorry I'm saying that, but it is. But it is true. So we have to, as mothers, we have to teach our sons to do that. I remember my late mother-in-law, when I got married, she told me, I'm handing over a husband to you who can match a sari to a fall. So it comes from there that it's not only women helping women. That happened in our dadis days, that you could say, mere pet mein dard ho raha hai, main kya karoon? Now it's more like, mere pet mein dard ho raha hai, why don't you make dinner? I am not going to take a medicine, I'm just going to rest, maybe with a hot water bottle. So it's the men who have to come in there. And then the other thing, no Zomato. That's why I'm saying, sir, that's why I'm saying the sons, because it's very difficult to change husbands and brothers. So, coming from there, government has given a lot to us, because when in 1988 I passed out and I joined, I'm basically a hotel management graduate. So now when I joined, of course, there was enough women around, but the top women were missing. Maybe 30 years later, when I see enough of them. Sometimes boardrooms are full of women, and men are the ones who should be asking for the special attention. So times have changed, and the paternity leaves that have come in. So it actually indirectly tells a man to take care of the child as well. And after the maternity leave also, the number of months have been increased and it has become more lenient. So there are things that are coming up, and again coming back to office where men are, they take care of you there also. They understand your needs. It's just that you have to make them aware. Since I come from a healthcare background, I was in awe when this new program of DIY, it isn't do it yourself, it's discover it yourself. Breast cancer awareness is happening during this month by Fortis. In that, it's a simple video which comes on your WhatsApp also, and it just teaches women how to inspect their breasts every 10 minutes in a month. So it has been a game changer, because when we are saying go to a hospital, maybe my maid wouldn't go. But when I share that video with her, because she has that phone, she might not be able to afford a health checkup, but she knows how to play on that video or watch there. So it becomes a lot easier. So maybe we can bring in more such programs where it is trying to tell them that you can do this to stop something which you may not be able to handle economically or otherwise. So those are my 2 bits. Thank you so much.
Thank you very much. So we have a few more minutes. We have 10 more minutes, so we can open the floor. But before I do, just to let you know that the Minister can't join us now. She's still caught up, but she'll be joining in the next session. So, sir, can you just introduce yourself?
My name is Rohit. I'm Managing Director of Feedback Medical Company. Thank you, ma'am. I think quite insightful, and I can relate quite a lot with the surrounding and the environment from where I came from. One thing, ma'am, I want to bring attention to the panel, something which is happening under our neck, even in the urban areas, and which we see quite often, but sometimes we don't pay that much attention about the females and the kids' health. That is about the nomad population. When we look at the beggars and when we look at the temporary camps across the roads, I sometimes feel so disheartened, looking at such a malnutritioned baby some lady is holding in her hand, and I wonder if there are mechanisms where even these section of population who are in such a developed city but still quite neglected from the basic awareness about the healthcare.
The governance issue, actually. I mean, how beggary is being allowed, and what we need to do with our floating population of people who are, just seeking some sort of a opportunity on red lights and all that. So it's a local governance problem. It can't be the health ministry's problem to cater to, we need to know what the state government is fully empowered to take care of these people, and they have all the wherewithal to do it. They can have outreach programs. There are several agencies who are already working with street children. They're working with children on railway stations, and so many people are there, and they're working in collaboration with government. So the government, if they take cognizance, they can take care of health issues, do outreach programs, do screening, do immunization. I think Pulse Polio program is such which kind of mops up all kinds of children, whether they are on the streets or whether they're in houses. So that coverage is definitely available. The state government has to do it.
Thank
One
you.
thing I'd like
Dr.
to add for
Mahajan, sorry.
Yeah,
Yes.
thank you. At the outset, it's been a wonderful interaction. Thank you very much. I wanted to take up, our legal luminary brought up that case of the young lady. At the outset, I would say that India is the most progressive amongst all states worldwide as far as permitting abortion is concerned. And it's only recently that from 20 weeks, they were permitted to abort till 24 weeks. And between those 4 weeks, as has been said, there are certain parameters which need to be fulfilled, and the medical fraternity needs to put its stamp on it. I'm a radiologist, not anyone from the legal sector, but I did study it and did talk to few of the judges who actually passed the judgment. And this was, when the case first came up, and 2 lady judges of the Supreme Court, they permitted the abortion. The mother is a lady who had a child, second child, went into postpartum depression, because of which, and in the postpartum period, you normally do not get pregnant, but she did, and became aware post 20 weeks. It did take a week or so for the judges to get around to passing or hearing the case. Now, the first judgment permitted abortion, even though it was beyond 24 weeks. If I remember correctly, it was 26 weeks. And that is when the abortion was to take place at the All India Institute, where one of the treating doctors wrote to the court saying that this is a normal fetus. The chance of, and just for some non-medical people here, this would be delivered It is not that it would be macerated and then brought out. This would be like a delivery which would be conducted after giving an intravenous medication. So the child is, or the fetus is going to be delivered, and the chance of it surviving even at 26 weeks with the kind of facilities we have in a neonatal ICU is significant. But if born at that stage, even though the child survives, it may be left eventually with disabilities just because it was a premature delivery. So this, when this came in front of the two judges again, they differed in their opinion. One of them said there should be no abortion. The other said the mother's will matters more and she should be permitted. Sent back to the Chief Justice, and 3-judge bench ruled, and there they ruled unanimously that abortion not be permitted because the fetus, they gave more emphasis to the life of the fetus than to the depression of the mother or the fact that the family may not be able to support the baby, where they said that it can be, the baby can be given up for adoption in case the mother does want to do that. It may just happen in due course of time, and we will know that the mother may get so attached to the baby when it's born that may not give it up. But so I think even this judgment does not leave any lacunae there, because generally what has been permitted beyond 24 weeks is when either the mother's health is at risk or it's a congenitally deformed baby that's going to be born. Here it was a normal fetus, and so I think in the scheme of things, if we look at it from a medical perspective, not so much from a legal perspective, I think justice has been delivered.
I have a question.
Just before we go ahead, shall we? Yes, so Garamasani had said that she wanted to make a comment. Was that you? And also just watching the time, we really only have like 3 minutes. Thank you so much. Just saying goodbye to Tanuja, who has to go.
Just
I think we'll actually need to okay.
The house is full.
All right.
Okay.
Thank you.
Right. Just one topic I thought that is less discussed everywhere. We have discussed good topics here, but one topic related to female or women health is around the cosmetic gynecology or the aesthetic gynecology or the urogynecology. This particular topic is something wherein there is less awareness, but there are 3-4 set of females who are needing these kind of treatment. The first set of females are those who are sexually active but not married, and there is a lot of social taboo around the marriage if she has to do a kind of an arranged marriage. The second set of females are those females who have just delivered, and because of delivery she has developed a lot of other issues like urine incontinence, vaginal looseness, because of which she is facing a lot of problems in her in her married life, and she is undergoing depression because of this, and that can be one of the reasons for divorces in our country. The third set of females are those we just talked about, menopausal women. Because of aging, I think there are a lot of dryness in that area, right? And there are a lot of kind of hot flushes and other issues which are coming up. So those ladies are also not well treated. Incontinence is coming in, and those are not well treated. So I think this particular field of aesthetic gynecology is something wherein the awareness is required, and we can have a lot of partners around the because the doctors are also like now ready to get into this particular field and learn about it, so we can have certain things around this.
Ma'am, just a minute. We would like to say a big thank you. You can continue in a minute after. We would like to thank Mrs. Roli Singh and Dr. Tanuja Nesri for their august presence over here. Yeah, I told. Yeah, मैंने बोला पहले रोली मैम का नाम दिया. For sure. Please, Rituji, can you connect for the photograph, please? We're still continuing with the session, but we can give them a big round of applause for their presence and for their remarks. Thank you, madam. Thank you, Tanisha, ma'am. Thank you. Madam, Madam, you can continue. I'm sorry for.
I think
you
heard
want
the
to
end
have a word
of your question. Yes.
Yeah, please. Sorry for the apologies.
So these were the three areas, like the person who is not married and sexually active and having the social taboo around it. Second set of female who have just delivered or have facing like issues with the husband and the family life. Third, the old age, the aging process where the menopause is leading to urine incontinence or vaginal dryness. Fourth, I would say that when we talk about females or the women leaders, the self-confidence is something very important. And when we say the females are beauty and they go forward for the beautification, I would say that inner genitalia is something which also brings in a lot of self-confidence. So this particular area of aesthetic gynecology or urinary gynecology, I think, is something which needs a lot of focus. What I have seen in my practice is that initially, like if I talk about 5 years back, there were no females in India who were ready to discuss about these issues. Right now we see even the doctors are ready for these kind of treatments. Initially, doctors were also not aware about such treatments, and the females were very shy about discussing these issues. I've seen my grand nannies and all that they were wearing diapers and all, but not coming to doctor and not disclosing about these issues. I think this particular area needs attention, awareness. And I would say this is not the problem which urban sector of India is facing. When we are like in pristine care, when we are operating on or doing procedures like this, we see a lot of females from tier 2, tier 3 cities coming and taking these procedures.
Can I come for a second? It was, in PGI Chandigarh, they started with multi-behavioral therapy clinic with regard to when you're talking of urinary incontinence, that's a major problem. And this has been suggested to all the medical institutions by Department of Biotechnology. Another thing is, counseling plays a very, very important role. This is one thing, preparedness for menopause and all. And this is where the things are now, the government's recommendations are also in line with this direction. So we need to, I think those of you who want to, have a look at PGI Chandigarh's multidisciplinary clinic and behavioral therapy clinic, it's many women have improved because of this.
Yes,
ma'am.
Because of these treatments, because I'm just talking about 5 years ago, there was no awareness around it. No doctors were ready to do it. Now the doctors are aware about these issues. Even the patients are coming for this issue. I tell you, with my one personal experience, there was a lady who was into her menopause and like she was taking treatment for UTI. When actually we checked her, it was just the vaginal dryness which was giving her urinary discomfort. And the procedures like laser and all really helped her. She was on antibiotic for last 10 years and she stopped taking after just a small treatment which was required.
Thank you very much. And thank you for raising that, because I think you're right that there is no discussion around this and it affects every woman eventually. So thank you very much. So I think we have time. Yes, I think. Sorry, we need to close.
One or two questions, Dr. Mahajan, and then he'll close.
So, no, we're not closing. False alarm. We have time for Madam, and then
I have a question actually. We know things have improved by leaps and bounds when it comes to women, the way things have been moving forward. But I think we still have to have people in the policy makers role, because whatever said and done, the men will not be able to understand what the menopausal woman would be going through, or post delivery what the women will be going to. I'm sure men wouldn't be able to understand. I think at the policy makers level, we need more women. We do understand in a healthcare there's 70% women, but only 10% make it to the boardroom level. So that is an area. Then second thing, what I felt was, government could make rules, but we will not be able to make people participate in it. So I think we have to make people responsible at some point, in the sense like females. See, a lot of incentives are being given by the government. So if the person gets checked XYZ things that they have to do in a year, then the incentive is passed on. I think that's when then people would become responsible, and utilization of whatever has been put forward by the government will happen. Thank you.
Thank you. Those incentives are so crucial. So, and yes, Madam.
Good evening all. I've been listening to all the panelists. But yes, the issues we face, I think we should think of rural women who are there in the villages, and those who are working with us, who are still carrying their images or visual impressions of their village or their bringing up. And the third category, I think, are the working women who are in the rural area. And fourth, most important, which we wanted to touch upon, was geriatric age women who are there. Now, considering all the issues that we have discussed, yes, menopause is one thing which we have to take care of, and we need to address this issue really, because they are not aware what the problems are. And we need, I feel, I am from Dr. D.Y. Patil Medical College, Dr. Vatsala Swami, Director Internal Quality Assurance Cell, and we were just discussing we should have a separate OPD or cell for discussing these issues. And now these issues are being discussed, I agree, openly. Now, earlier the taboo was there, but no, now that regarding menstrual menarche and then the menopause, we are discussing openly, and men are also aware of these problems. But like Madam just now said, that they are coming forward to help you here in the urban area, but in the villages still, the woman is supposed to be, as Aurora Madam mentioned, she's supposed to be doing everything. And I always say that as a woman, whether you are working or whether you are a homemaker, you should have that me time. That me time is very, very important. You should take care of your health. Whether it is your menopause, whether it is childbirth, whether it is antenatal, everything is you have to take care. Because you are taking care of so many in the family, but there is no, yes, everybody thinks about you, but nobody to take care of your health. So you have to give enough time for that. And the second issue is mental health. Now, these days, especially urban, with nuclear families, we are seeing that the mental issue is become very, very important. We are dealing with it, and we know how it is. A lot of counseling is required. So, like I think Mahajan Madam mentioned, we need to take a firm resolve that each one of us will handhold at least 10 or 15 women, and then take care of all these issues, like starting from menarche, like self-examination of the breast. I think somebody was talking about, very, very important every day. And how to do it, video is there. Now that video is circulated in WhatsApp group, and they all can see, like everybody has a phone. That is not difficult. Now, apart from the mental health, last point is adolescent. Adolescents are having a lot of issues these days. Whether we agree or not agree, they are there at home, they are there in the hostels, they are outside. But how to deal with adolescent is also an act. It is strategically to be planned, and then only their health will be good, and our health also will be good. Mental health I am talking about. Mental health has become a priority these days. So we need to, as women, we need to address all these issues. And stress, Madam said that we keep suppressing our stress. We don't show it, but that stress affects our health in different ways. So ultimately, we are the sufferers. And then we have that guilty feeling that when we are there in the hospital, that what is happening at home, whether they are able to take care of themselves, who is there to take care of them. So these issues come one by one. So I feel that all of us take a resolve that we will take and handhold about 10 to 15 women and see to it that they're being helped with all these awareness programs that are being conducted. And last but not the least, school. We were talking about school, but I am sure I have visited 2 or 3 schools. We went for camps, but the washrooms, the hygiene is very, very important there. So that should be again Anganwadi workers or teachers. They have to be, it is not once. You have to keep going there every now and then to stress upon this. Then only menstrual hygiene there in the schools will be taken care of. Otherwise, a lot of infections and urinary infections. So we have to be sure what we are talking today. We have to take it further in the society and see to it that many of the women who are unaware of these things are being helped, and those who are aware, they take care of themselves. And ultimately, finally, our health is wealth. So we have to take care of our health. With this, I thank everybody. I thank Ficci for giving me this opportunity. Thank you.
Thank you very much. I think you've done a great summary of so much of the discussion.
Thank you so much, Suzanne, for moderating this session so well, and thank you all the beautiful ladies over here. But in fact, I need not tell the thanks, because we have someone who will extend the vote of thanks for this session as well as for the entire conference. Please help me one more time welcome Dr. Harsh Mahajan to do the honors, please. Thank you.
Can I take? Thank you.
All good things, they say, must come to an end. But when they come to an end amongst such beauty, I think there can't be anything better. 2 days, 2 hectic days, full halls, great proponents of the healthcare sector, legal luminaries, and beautiful ladies. It's been, I think, quite an enriching experience for most of us. A lot of participation from members who came and joined, experts who spoke, wonderful Mrs. Sharmila Tagore last night for the awards ceremony, and 17th Ficci Heal conference. Awards which have become probably a standard of excellence in the healthcare field. And then we had people from other walks of life, from journalism to the hotel industry to school education, who came and shared what they feel about the healthcare sector and how there is synergy between multiple sectors. And finally, thank you very much, Susan, for doing this. It was a great job. It did seem a little, despite the wrist and the burnt hand. Dr. Lal, of course, Dr. Singh, who's the chairman of Ficci Heal for this year, and all the other friends. Thanks to the sponsors, thanks to the Compare and members of the Ficci Healthcare Service team who've done, I think, a great job. What I'm hearing is that everyone has benefited from these 2 days of interactions, and we look forward to seeing all of you again. And let this not be the end, even though I said all good things must come to an end. But let's continue the conversations as we go along. I'm sure we've shared a lot of business cards amongst us. Let there be collaboration, and let ultimately the goal is for healthcare in this country to get better and better, and for there to be universal health coverage, where the government alone, as we've heard time and time again, they can't do it. So it has to be a collaborated effort between the public and the private sector. And towards that end, I can assure you that Ficci and its members and its organization will always be striving to make that happen. Thank you all very much.
Thank you very much, sir, for a warm thank you note. And
Ladies, do take care of yourself, and men, oblige us by doing so too. Thank you very much. This is Dhwani signing off. Bye-bye. Stay happy, stay healthy till we meet next. Thank you.